delegates, faculties, and everyone present here. Myself, Dr. Rupak Chatterjee, welcome you all on behalf of Association of Metabolic Obesity Physicians and Clinical Endocrinologists to our third national conference, EMOCON version 2. So to start with this session, may I request Dr. P.S. Mondol sir, he needs no introduction, to come on the chair, and may I request Dr. Partho Vishwas sir to please come on the chair sir, and may I for the first speaker, may I request Professor Dr. Anchin Kalia, Madam. Madam needs no introductions. She is Senior Professor, Department of Medicine and Unit Head, MGM Medical College, Jaipur, to please come on the stage, Madam, and start your session on optimizing muscle nutrition. Over to you.
Thank you so much, and a very warm welcome to all of you. It has been a great conference since last 2 years, and I was a part of it, designing the scientific program. So I welcome you all on behalf of EMOCON 2026. And I would be talking today on optimizing nutrition. And can I have the slides, please, from the beginning? Okay. So it's a very interesting topic, and as we all know that no matter how much dietary intake and prebiotics, probiotics, we keep hearing around the day with everyone saying, thoda prebiotic le lein, probiotic le lein, your gut will be healthy. So over the years, it has now been emphasized that how much important gut is in our day-to-day activity, including our muscle nutrition and general well-being. So I would like to thank at the beginning the chairperson for the kind introduction and the disclaimer that this is a sponsored session by Zydus Wellness, and they've been doing really well in this session. So my thanks to them also. So when we talk about protein in India, and we will all be agreeing to it, that protein intake when we see our diet is very, very negligible. So what we emphasize is more is on carbohydrates, and which in the form of roti, whether it is a multigrain roti or rice, we are always worried that हमने roti ठीक से खाई या नहीं खाई. So even when the patient says कि हमें भूख नहीं लग रही है, they mean that we are not taking adequate amount of roti and rice in our diet. That's why we don't do well. But we are all unaware that around 90% of our daily protein requirement, how does it happen? And as we all know, when we have health issues which are associated with low protein intake, they can cause weakness and increased hunger, increased susceptibility in infections. Like we all know, when we have ICU patients and they have low protein intake or their albumin is low, we always say that you need to build up the nutrition because these patients would have a prolonged ICU stay. So that is how important protein is there in our regular diet. Also, because of low protein intake, it can cause brittleness of hair and nail and increased risk of stress fractures. So what is the adequate protein recommendations for adult? So when we compare India to the Asian population or the Western population, we all know that India, we have a very poor knowledge as well as intake of protein diet. So for RDA recommendation for protein in adults is 0.83 gram per kg of body weight. So when we have a patient who is around 60 to 65 kg, we say that the protein amount would be around 54 grams. And when a person is doing body weight exercises or going to the gym or doing exercising or doing running, so this increases to 1 to 1.5 milligram per kg of body weight. So what life course changes are there which increase or decrease your muscle mass and strength? So one is your lifestyle habits, which is very important. So impaired nutrition, reduction of physical activity, and consumption of substances like alcohol or cigarettes, they cause decrease in your muscle mass. Also, there are two important genetic factors such as the IGF-1 gene and the vitamin D receptor genes that contribute to variation of skeletal muscle mass. So this was also a surprise for me. I read a long time back that, you know, when we say that I used to say that after 40 your muscle mass will come down, but now all the studies say that as early as 20 years of age, beyond that, and more so after 30, there would be a decrease in your muscle mass. So what, a few words about the prevalence of chronic health condition in Indian adults. So prevalence of irritable bowel syndrome is around 4 to 7.5%. Prevalence of obesity is around 13.85% to 57%, which is ever increasing. And 5 to 6 out of 10 women between age 30 and 49 are abdominally obese. So these are the, and similar is with the osteoporosis. So these are the chronic health conditions which are prevalent in Indian adults. So what factors are there which affect the muscle health and the role of nutrients in them? So when we have muscle protein, this acts as a primary repository of the amino acids, the essential amino acids and the branch chain amino acids and the free amino acids, and they have this function of increase in energy production through oxidation, gluconeogenesis for blood sugar regulation, synthesis of immune components and plasma proteins, hormones, and so on and so forth. Everybody knows the importance of protein in the diet. So what are the factors which influence muscle development? One is the muscle contraction during exercise. So I always tell my patients that how important strength training is there when you are doing exercise. So cardio metabolism is one, but strength training is equally important, because when we stimulate muscles, then only they have this triggering of repair and synthesis of strengthening of muscle mass. Then is the amino acid intake from the diet. So when we have good amount of essential amino acids in the diet, they improve in the muscle repair and growth, highlighting the importance of the dietary protein. So when we, what are these factors? Like already discussed, alcohol consumption, insufficient energy intake, excess calorie intake, and vitamin D deficiency. All of them together with cigarette smoking and inactive and sedentary lifestyle, they cause decreased muscle protein synthesis, increased muscle protein degradation, and loss of skeletal muscle mass. So there is a milieu of proteins, calcium, and vitamin D on musculoskeletal health, which is known to everyone. So likewise, proteins, again, like I said, they have these essential amino acids, and they are crucial in the growth of your muscles, physiology, and metabolism. Also, the protein, they constitute approximately 50% of your bone volume and 1/3 of its mass, providing the matrix of the bone. I think there's something wrong with the slides. Then likewise is the calcium and vitamin D. Also, vitamin D has a receptor which has got an important role in the protein metabolism. So this is important. Gut wellness and its role in nutrient absorption. This is a very important slide which will come. So maintaining the gut hormones, maintaining the gut bacteria, which are the good bacteria in the gut, they help in the proper digestion and absorption of proteins as well as other fibers. So importance of a healthy gut is if it is effective in digestion and absorption. It improves your gut motility. It has a stable intestinal, helps in the stable intestinal microbiota, and again effective in the immune status, because the plasma cells, T cells, helper cells, everything has got a good absorption through the gut. So again, these gut microbiota, they help in the synthesis of vitamins and amino acids. They metabolize non-digestible carbohydrates. They also inhibit growth of pathogenic bacteria. They prevent allergies by modulating the immune system, because the gut is the biggest immune system organ for the immune system. It improves protein digestibility, gut permeability, and reduces the translocation of pro-inflammatory, which is very important, molecules across the gut epithelium. So what is the role of pre and probiotics and their impact on gut health? So what is prebiotics? So prebiotics are non-digestible oligosaccharides, and they undergo transformation by beneficial colonic microorganism. That is the probiotic. So we keep saying prebiotic and probiotic. That is how it is there. So non-digestible oligosaccharides are the prebiotics, and they undergo transformation in the gut with the help of the microorganisms, which are also the probiotics. So what does the prebiotic do? They inhibit the pathogens, reduce allergy risk, alters gut permeability, produce production of metabolites, and enhancement of calcium metabolism. So what is the effect of probiotics on, this was prebiotics. Now what is the effect of probiotics on human health? Probiotics, as we all know, has got a wide range of action for the gut. So one, it helps in the immunomodulation. normalization of gut microbiota, and the metabolic effects like the synthesis of vitamins. They lower the cholesterol, improve the dyslipidemia, and improve the lactose intolerance. So what happens, what does these pre and probiotics do in protein absorption and muscle integrity? So they alter and regulate the intestinal flora. They induce host digestive protease and peptidase activities and reduce harmful protein fermentation, which influence the dietary protein digestion and utilization. This is a very good slide, and I'm not sure whether it is visible or not. Uh, So what is happening is that you have these protein organisms, protein rich diet, it goes into the intestine, and you have these gut microbiota which is there. It's a very good slide, we can also enhance it, that's if you can see it, I'm not sure. And then you have these microbiota or the probiotics which digest the proteins and help in the absorption of proteins which are easily adjusted and utilized by the body. So we will be talking a little bit about the Bacillus coagulans unique, which is a probiotic. So it improves again the adult gut health and helps in the muscle strength. How? So it augments the muscle strength by optimizing the protein absorption. Also, it helps in the concentration of whey protein and improves the plasma amino acid levels. So there was this study which was done it was a 14-day study, and around 1300 milligram per kg of body weight of these colony forming units were given to the patient, and it was seen that there was an improvement in the colonization. The rigorous toxicity studies were all done, there was no toxic effect, and there was no adverse side effects which were reported. So what is the unique property of this particular bacillus? It is resilient in nature. It has got digestive enzymes. It has got antimicrobial properties. It helps in vitamin synthesis, and it has got a probiotic potential. What is the clinical evidence? This is a very good study, and it was seen that it was a randomized double-blind study, and it was seen that in the intervention group, they were given 20 gram of whey protein plus 2 billion colony-forming units of Bacillus coagulans, and the placebo group was given whey protein powder plus lactose. So it was seen that the total increase in fatty acids, free fatty acids, was up by 16.1%. The brain chain amino acids, including isoleucine and valine, they were increased by 33.1% as compared to placebo after 16 days. So it was seen that supplementing whey protein with a good amount of probiotic, it significantly helped in the absorption of the brain chain amino acids and reduced the risk of colonization. Also, it helped as a improvement in the exercise performance. Like on the right hand side, you can see that the patients underwent the leg press. It was seen that the patients who were on whey protein plus this bacillus, there was an increase or an improvement in the leg press exercise which they did in the gym by around 7.86%. So again, this was it was again a similar study, and it was seen that for conclusion, it was seen that the bacillus coagulation demonstrated effectiveness in decreasing the symptoms of constipation, indicating it is a potential and is an effective treatment for functional constipation as adults. This was something very new for me when I read the slides, that if you give a good amount of probiotic like bacillus coagulation, after 4 weeks of good randomized trial, it was seen that it helps in functional constipation as well. So I think so many of our patients come which have these problems, and this can be given as a good alternate also. So dietary fibers and health benefits, I'll just quickly go through the slides. So when we have dietary fibers, they are the insoluble dietary fibers and the soluble dietary fibers. So insoluble dietary fiber, I'll just take 30 more seconds. They're non-fermentable, and the soluble dietary fibers are fermentable. So what is the highlight of the fructo-oligosaccharide prebiotic? So we talked about probiotic, now is the prebiotic. So fructose oligosaccharide, FOS, is water soluble, it is highly hygroscopic, and it's thermally stable. So the sweetness is also less, and it is resistant to hydrolysis by the human digestive enzymes. So when we take a prebiotic along with, as I said, probiotic, it helps in promotion of growth of certain microbes, and they undergo fermentation by the colonic flora. So by this prebiotic, so the production of toxic metabolites are less as compared to the other ones. So what is the health effect? So it is a prebiotic effect released from the constipation, like we all know, the dietary fibers, facilitates the mineral absorption and the modulation of the immune system. The clinical evidence is quite good about the impact of oligosaccharides on gut microbiota. So to conclude, this FOS, it positively influences the gut microbiota by promoting the growth of bifidobacteria and reducing the plasma concentration of the bacillus, and lasting even after the FOS intake period was reduced. So 4 weeks the patient had taken this, and 4 weeks it was, after the 4 weeks also, while after stopping the dietary fibers, the study was concluded. And it was seen that even after the stopping of this fibro-oligosaccharides, the release of bifid in the stool was there. So to highlight again, so muscle loss again begins around 30 years of age, and it is due to various lifestyle and other problems. So musculoskeletal integrity is crucial for maintaining all the protein and calcium and vitamin D metabolism. High protein supplementation, including pre and probiotics and physical activities, it can mitigate muscle deterioration and enhance muscle function. And pre and probiotics, including Bacillus coagulum, is helpful. Thank you so much for your patient listening. We'll take the questions after the...
Thank you. We will take the questions
after
at the end of this session. Now, this session is diabetes and women. It's a very relevant session, I believe. Diabetes in women, not all about the glycemic control. It affects every stages of their life, starting from the adolescence, reproductive periods, and pregnancy, even the postpartum period, menopausal stage, and also the old ages. And in these all stages, they face unique metabolic, hormonal, cardiovascular, and psychosocial challenges. And we need to address those challenges appropriately, and for that, we need coordinated care from diabetologist or a physician experienced in diabetes management, or endocrinologist, nutritionist, gynecologist, and obstetrician, as well as diabetes educator. And now we have Dr. Rana Bhattacharya. He will be talking about the glycemic control from preconception to pregnancy, or what we say that at the end of pregnancy, and also the control during the postpartum period. Dr. Rana Bhattacharya doesn't need any introduction, and Dr. Bhattacharya, over to you, please.
Thank you. Thank you, Chairperson. It's a very good morning to all of you. So a quite important topic regarding glycemic control from conception to postpartum. This is extremely important because there are some discussions there in various meetings regarding GDM, diabetes in pregnancy. However, a very crucial point that glycemic control around conception as well as after delivery is very often neglected. So these are the objectives of my talk today: to understand the importance of glycemic control across reproductive timeline, and we'll review the glycemic control parameters in different stages and its importance, and we'll how to apply various evidence-based strategies. And during this discussion, what I won't discuss, that how to monitor and manage various comorbidities and complications, because I'll strictly focus on the glycemic aspect of it because of the time limit that I have. And also I won't go into details of various screening processes, their controversies, and all those things. I will just limit my topic within the glycemic control. So why it matters? Now, it's very important because of many a thing. First, from maternal viewpoint, on the short term, diabetes itself can lead to various complications of pregnancy, including preeclampsia, polyhydramnios, infection, increased rate of cesarean section, and progression of pre-existing retinopathy and chronic kidney disease if they are already there. Not only that, over the long run, there is increased incidence of type 2 diabetes, cardiovascular disease, and recurrence of gestational diabetes in subsequent pregnancies. There are fetal complications as well. There can be congenital anomalies and increased risk of miscarriage, and later on, even it doesn't end there, when a fetus who grew in the milieu of uncontrolled glycemia later in life can develop various complications like obesity and type 2 diabetes. But before that, very importantly, in the neonatal period itself, there is increased chance of hypoglycemia, hypocalcemia, respiratory distress syndrome, neonatal jaundice, so on and so forth. And one of the very important thing in case of pre-existing diabetes in pregnancy, that one has to control diabetes strictly once the patient starts planning conception. Why it is so? Because it has been seen the risk of congenital malformation of fetus directly correlates with the degree of glycemic control at the time of conception. So, this preconception care is extremely important, and it should start at least 3 to 4 months before conception, because once the patient conceives, the critical period of organogenesis starts then and there, even before the person is aware, the lady is aware that she is pregnant. So the first 6 to 8 weeks is very crucial, and therefore the good preconceptional care is extremely important. So what's the aim? So once a lady plans for pregnancy, we should aim for near normal glycemia, of course without undue hypoglycemia. And HbA1c target should be less than 6.5 whenever possible at the time of conception. So it's very important to discuss the importance of optimization of glycemic control at that period. If the patient is on multiple OADs, please stop all those. Intensify insulin therapy. You can continue with metformin. Do CGM, and if needed, SMBG, and if needed with CGM. We should stop teratogenic drugs, like we should stop statin in preconceptional period unless it is the patient has a very high risk of cardiovascular disease. In that case, we may continue it in a very rare situation. And we should screen for retinopathy, nephropathy, and cardiovascular disease before the lady is planning for pregnancy. And of course, we should start with folic acid and ask them to continue with effective contraceptive practice until they achieve a good glycemic control, that is A1C less than 6.5. And this is, I focused on this particular point because in my clinical practice what I saw, this is an extremely neglected aspect of management of hyperglycemia in pregnancy. Once the lady becomes pregnant, then they get managed well. But this preconception period is extremely important for these multiple reasons, particularly prevention of congenital malformations. Now, once the pregnancy happens, then our antenatal glycemic target changes. Okay? So there the target becomes even more stringent. Here we usually do not use HbA1c. The fasting glucose level should be less than or equal to 90 or 95. 1 hour postprandial, which is preferred by many including me, should be less than or equal to 140, and if you prefer 2 hours, it should be less than 120. Here the aim is different. Here the main aim is to reduce macrosomia and other complications associated with pregnancy, not congenital malformation, because that period has already passed. So how to manage? First with lifestyle. I won't go into detail of medical nutrition therapy, just a point to remember that in second and third trimester of pregnancy, there is increased caloric requirement in the tune of around 300 to 400 kilocalories per day. That's number one. And number two, pregnancy is not a good phase for weight loss. So here, even in a very obese patient, we tend to ask the patient to maintain that weight. Also, undue weight gain is not warranted. So, this is extremely important. For physical activity, that should be done in discussion with obstetricians. How much physical activity is permitted, particularly in the first trimester and nearing delivery. In the second trimester, it's okay. Most of the physical activities can be undertaken. Regarding pharmacologic therapy, insulin is of course the gold standard. Metformin can be used in selective cases. Just to give a few examples, a case of pre-gestational diabetes, who is already on metformin, you can continue with that. In a gestational diabetes, if the hyperglycemia is not very severe, but it cannot be controlled with lifestyle management alone, you can give metformin. But in most other situations, insulin is the preferred agent. Glibenclamide is recommended by some authorities, but it's highly controversial. Please avoid it whenever possible. And it's possibly only indicated in cases where the delivery of or giving insulin is impossible, which is practically nowadays, we should not do this kind of practice. So it's better to avoid glibenclamide in practically all the situations. Now regarding monitoring, SMBG is most practical one because, as I've said, HbA1c has a very limited role in pregnancy. There is no fixed target. You can examine the trend of HbA1c, but there is no fixed target here. And in some cases, CGM can be used when you feel that SMBG is not sufficient or patient is motivated enough for a very tight glycemic control. Intrapartum glycemic control is extremely important, that is during delivery. Okay? So here during delivery, we should discuss with gynecologists that the intrapartum or during delivery, the glucose target should be very stringent, between 70 to 110. Why? Because it's one of the most important predicting factor in neonatal hypoglycemia. So during delivery, if blood glucose level is grossly uncontrolled, then there is increased chance of neonatal hypoglycemia. And IV insulin is often needed. One of the very important points to note is that at delivery, whenever the placenta gets separated, there is a sharp drop in insulin requirement if the patient is on insulin. So we need to adjust insulin dose very rapidly once the placenta gets separated. Many a times we may not have to give insulin. So this is also a very important point you need to discuss with your gynecologist. Regarding postpartum care, again, just like preconception care, this postpartum care is often neglected. So once delivery happens, then the physicians and the new mother herself often forgets about her status. So not only in pre-gestational diabetes, where of course the glycemic control is important, even in GDM, it is very important to OGTT between 6 to 12 weeks after delivery, because there is a very high risk of development of type 2 diabetes in subsequent stages once there is GDM. And lifestyle intervention should continue in this postpartum care. During lactation, if needed, you can give insulin. Metformin may be continued. Other drugs better to avoid. There are some studies with glipizide, but again, it's better to avoid sulfonylureas if possible. Now, in long-term follow-up, as I said, there is an increase in lifetime risk of type 2 diabetes even after delivery. So it's better to do OGTT yearly following delivery. And before planning subsequent pregnancy, of course, again, just like I discussed with pre-GDM, one has to ensure HbA1c less than 6.5. And in addition to that, cardiometabolic risk management is there, because these women are prone to various cardiometabolic disease later in life. So we should not forget about that as well. So at the end, I will end here that glycemic care, of course, it should start before conception, preferably 3 to 4 months before planning pregnancy. Tight control at that period reduce congenital anomalies and various complications. And continued glycemic control, even with most stringent target during pregnancy, is essential. And sometimes we need multidisciplinary approach. And in many situations, we do forget about postpartum care. So lifelong monitoring of these individuals is extremely important. So these are my references. Thank you for being patient listeners. Thank you.
Thank you, Dr. Rana Bhattacharya, for a crisp and a very lucid presentation. There might be many questions which will be taken up later.
Thank you.
So, Dr. Bhattacharya, please be seated. Dr. Nandini Chatterjee has arrived. The next speaker is Dr. Nandini Chatterjee. It's related to women and diabetes, the hormonal influences in diabetes in respect to women. So, madam, the podium is yours. I think Dr. Nandini Chatterjee needs no introduction. She is one of the pillar of API and one of the most successful organizer of EPICON 2025, other than his credentials which are given over there. And she's the chief editor of JAPI and the professor of medicine, IPGMER. So, madam, let's move on.
Yes.
Hormonal influences in diabetes in women.
Thank you very much, and a very good morning to all. So, this topic that was allocated to me, I found it quite difficult because it ultimately reminded me of my first year, second year days. Basically, it dwells on physiology and how physiology is dysregulated in diabetic women. So first, as we know, that the burden of type 2 diabetes is becoming explosive with the passage of time, and diabetes is affecting around 8.2 million women in India. That is the current statistics, and it is predicted that it is going to increase in the coming decades. The prevalence of diabetic cases in India are 24.4 per thousand women. However, this varies in various geographical areas. The prevalence of gestational diabetes mellitus has a wide variation between 3.8% and 21% in different parts of the country. But we know that for a given population, the prevalence of GDM corresponds to the prevalence of impaired glucose tolerance in non-pregnant adults. So, as we know, there are different types of diabetes, and their association with gender slightly differs. For type 1 diabetes, which occurs in the younger persons, basically gonadal hormones are protective. For the young persons who have all the sex hormones in normal percentages in the body, they are protected from type 1 diabetes to some extent. But adolescents who have reduced serum estrogen activity are prone to develop this form of diabetes. In type 2 diabetic patients, we see that as age progresses, the risk of getting diabetes increases. So there are more diabetic women after the age of menopause and in the elderly. For pre-diabetic patients, it is seen that women have more propensity of postprandial hyperglycemia, and that is not good because it is having a greater risk of mortality due to increase in cardiovascular risk. So given these figures that we have mentioned, we need to look into the underlying causes. Why is this happening? Now, it must have been discussed, and we all know that it is multifactorial. There is genetic predisposition, traditional risk factors, socio-demographic factors, and definitely, in case of women, hormones play an important role, and that is actually the topic of discussion today. So, women undergo various life stages, and the hormonal milieu is different for each of these life stages. So there is a menstrual phase, a woman may become pregnant, at that time the hormones are different, and of course there comes menopause. So just a brief look at this slide where we see that in the monthly cycle there will be a follicular phase and the luteal phase. So in the follicular phase, we have a surge of the follicular stimulating hormone, the luteinizing hormone, and the estrogen levels will be high. Whereas after ovulation, the progesterone levels are shooting up. So what is the effect of this hormonal variation in the two phases of the menstrual cycle? Progesterone and estrogen fluctuations have direct effects on blood sugar. There is an increased risk of hypoglycemia in the early phase, that is the follicular phase, of course, in patients who are prone to it. And there is higher insulin resistance and hyperglycemia during the luteal phase. So, dominant estrogen levels improves insulin sensitivity. And therefore, in the follicular phase, when estrogen is abundant in the body, we have good insulin sensitivity. Whereas in the luteal phase, this is reversed. High levels of progesterone override estrogen and promote insulin resistance. Significant rise in blood glucose levels are therefore seen 3 to 7 days before menstruation. So this photograph or slide shows how estrogen is affecting various target organs. So in the adipose cells, estrogen is diminishing inflammation and hypertrophy, and it is increasing insulin sensitivity as well as the hyperplasia of the adipose cells. In the pancreas, insulin biosynthesis and secretion increases, there is better beta cell survival. In the liver, its action is decreasing gluconeogenesis. This is extremely important because as we know that our fasting glucose levels depend on the degree of gluconeogenesis that is happening in the body. In the muscle, the estrogen is helping in glucose transport across the cells and insulin uptake. I don't know, it's not moving. So, what are the hormones at play? Who are the key players who are ultimately deciding the metabolic milieu of a woman's body? Given in red is estrogen because it has a protective effect on the metabolic system of the body. Other hormones which are directly related and are influenced by fluctuations of estrogen are progesterone, insulin, cortisol, thyroid hormones, androgens, and vitamin D. Now, primarily, estrogen and progesterone are the central regulators. They control energy expenditure, fat distribution, and insulin sensitivity. Estrogen, as I've already said, acts as a protective factor. It improves the sensitivity and reduces chronic inflammation. We are all aware that chronic inflammation plays a very important role in each of the metabolic diseases that we encounter. Estrogen directly impacts the cardiovascular system, liver, and fat tissues to maintain metabolic stability. When estrogen levels are decreasing, we have all the problems with insulin resistance. Estrogen itself, as well as its effects on other hormones, together cause these effects. So, progesterone, what happens when estrogen is high and low progesterone is there? There is a situation of estrogen dominance. Serotonin and dopamine, which we know control mood and anxiety and depression, they decline with declining estrogen. Another very important player is the cortisol. The cortisol will be fluctuating along with estrogen. A fluctuating estrogen level results in increasing sensitivity to stress and anxiety. When we had gone into the factors that increase metabolic diseases, it is now definitely proved that mental health and anxiety, depression, all of this has a definite effect on increasing obesity, increasing metabolic diseases in persons. Thyroid hormones. We know that in diabetic patients, almost 30% of them may have associated thyroid dysfunctions. Increased thyroid hormones may lead to increased metabolic activity, increased blood sugar, and decreased efficiency of insulin, while hypothyroidism slows down metabolism, potentially causing low blood sugar levels, though this may not be clinically evident at all times. Lastly, one slide on androgens. When menopause sets in, we know that estrogen goes down and there is a relative increase in androgens in the females. And androgen does all the things that estrogen didn't do in the first half of their life stage. So androgen will increase hypertrophy of the adipocytes. It will decrease glucose uptake. It decreases beta cell survival. It seems that in women, the androgens are having a very bad effect in each and every target organ. In liver, it will increase steatosis, increase inflammation and gluconeogenesis. And in muscles, there is decreased glucose uptake. So now all these slides that I have gone through more or less summarizes that we have the good hormone, which is estrogen, which is helping, which is protecting, and we have the other hormones which are holding hands and being affected by its fluctuations in a woman's total metabolic journey. Now, few slides about diabetes in pregnancy. I don't want to go into detail. I'm sure there will be many more talks on gestational diabetes. Just a few points is that gestational diabetes, it is more in women who are obese and overweight, but in normal women also, they become susceptible to gestational diabetes because of the hormonal milieu. Certain placental hormones actively oppose insulin action, ensuring adequate glucose for the fetus. Nature has made the body in such a way that the fetus is always being provided with adequate glucose. In doing so, sometimes there may be certain disease processes that take upper hand. So the human placental lactogen, placental growth hormone, and progesterone as well as estrogen all may have an effect to lead to increased insulin resistance and hyperglycemia. There is also associated dysregulation of the adipokines as well as a pro-inflammatory milieu. Role of insulin resistance and the insulin-like growth factor 1 is very important also in patients who are developing in gestational diabetes mellitus. Add to that effects of cortisol, effects of elevated glucagon, and decreased sex hormone binding globulin. What is the consequence? The consequence is a milieu of chronic inflammation and hyperglycemia. The third section of my talk is the hormonal milieu and effects of menopause on diabetes. A decrease in estrogen levels lead to increased insulin resistance and potential weight gain, raising the risk of type 2 diabetes. Now here there is a bidirectional relationship. Diabetes mellitus accelerates menopause in some women. They may tend to experience earlier menopause compared to the non-diabetics. Again, if there is early menopause, it will lead to increased risk of developing type 2 DM. So, time is over. Okay, I'll skip some of the slides. Basically, I will not go into the detail. In menopause, as I've already mentioned, there is decreased estradiol and relative increase in androgen. And as I've already mentioned, the functions of these two hormones, you can surmise that what will be the final effect. Now, the talk also included effects of complications of diabetes mellitus due to hormonal influences. So, it can be said that cardiovascular complications, especially in women who are elderly, older age, mature women having menopause, there is a higher atherothrombotic risk, and the causes are evident because of the hormonal milieu. Sex hormones may be a key to explaining differences of development of diabetic nephropathy between men and women. It is said that before menopause and after menopause, there is a difference in risk of developing nephropathy, and of course, it increases at the latter part of the woman's life. Postmenopausal women with diabetes develop end-stage renal disease at a faster rate than women, and the decreased level of estradiol reduced creatine clearance and increased albumin excretion and tubular fibrosis in the kidney. As for neuropathy, it is said that progesterone is neuroprotective and repairs myelin damage and regulates inflammation. It can also improve structural changes and inhibit fibrosis. However, estrogen also has protective effects. So when these hormones are on the wane, again, the risk of neuropathy increases. The same goes true for diabetic retinopathy, hepatic steatosis, as well as acute complications of diabetes. Even infections like urinary tract infections and yeast infections in the vagina are increased after menopause. So what are the key effects of the hormonal fluctuations? Insulin resistance, hyperglycemia, obesity, endothelial dysfunction, and chronic inflammation. One slide about hormone replacement therapy. There is a lot of controversy. Why? The pros may be that if you replace with a transdermal patch, of course, there may be improved glycemic control and reduced fat. However, always there is a risk of thromboembolism, breast cancer, and potential of strokes. However, decision about hormone replacement therapy should be multidisciplinary after discussion with the specialists. And we have specialists here and we may discuss it about it. So thank you very much.
Thank you, madam, for a lucid and uh, very well explained different states of the woman, starting from menstruation, the reproductive age group, and the menopause, where the interplay of the hormones affect the diabetes. Thank you, ma'am.
Thank you. Thank you very much.
Now we invite Dr. Shagorika Mukhopadhyay to the stage. She is one of the brilliant speaker and one of the most privileged and very important endocrinologist of this city. So, ma'am, may you start your deliberation?
Thank you very much, organizers, for the kind introduction. I'm very privileged, really, and I'm filling the gap for someone who was unable to come because of some family emergencies. So bear up with me a little bit, please. I prepared the talk in haste at last hour last night, so just bear up with me. Right. So I'll be talking about sarcopenia and metabolic risk in women after menopause, in women with diabetes. And my talk has been made a bit easy, or maybe you will understand the flow a bit easier since taking a cue from the last speaker's talk. So sarcopenia, how do you define sarcopenia? Very easily, sarcopenia, sarc means muscle and penia means poverty, or the lack of muscle or decrease in your muscle mass is called sarcopenia in very simple terms. So on the left hand side, you can see a cartoon of a normal mass, and the right hand side, the cartoon shows that the musculature is being replaced by fat and muscle mass decreases. So there is a rapid decline in your skeletal muscle mass and strength. Muscle mass anyway declines with age, and with every decade of life, you have got about 5 to 6% of muscle mass declining, and that is called primary sarcopenia. And if you have muscle mass declining due to a disease effect, say for example HIV, due to some malignancy or cardiovascular disease, etc., it's called secondary sarcopenia. After age of 70, of course, sarcopenia becomes a bit accelerated, and this leads to, because of poor muscle mass, leads to a decline in your physical performance, increased risks of fall, increased risk of becoming fragile. And we didn't have any concept of sarcopenia even about a decade ago, but now it's being recognized as a disease condition since 2016, and the International Classification of Disorders have also given it a disease code. Now, skeletal muscle play a very, very crucial role in type 2 diabetes because it's one of those organs, apart from the liver and your adipose tissue, that is responsible for glucose utilization or utilizes insulin for uptake of glucose. So this makes it very important for maintaining your energy balance and homeostasis. People with type 2 diabetes have got increased risk of developing sarcopenia in comparison to the normal population, and there is a direct link which coexists between sarcopenia and type 2 diabetes. Now, if you look at this cartoon, which talks about how does your body composition alters as you journey from being your normal self or premenopausal to being postmenopausal. So when you're in the premenopausal state, you have got a normal level of estradiol, which is very much responsible for maintaining your muscle health, maintaining your cardiovascular status, and also you have got an increased amount of AMH as well. And as you journey, during this period of time, what happens? Your fat mass is at stability. You have got, and if you develop diabetes, your insulin resistance goes up, dyslipidemia goes up, and as you journey through menopause, there is a sharp decline in your estradiol level, and this increases the fat inside your muscle. As your muscle mass decreases, it gets replaced with fat. There is increased amount of insulin resistance and a lot of other cardiovascular changes. It happens. So menopause is like a metabolic inflection point in your life, and there is an abrupt decline in your circulating estradiol levels, and estradiol level really contributes to the abnormal adipose tissue deposition. Visceral adiposity increases, which contributes to your insulin resistance and contributes to worsening of your diabetes, insulin sensitivity, which again depends upon the amount of muscle mass, also declines because of declining muscle mass.
So what is roughly the epidemiology of sarcopenia? How much is it present? Roughly about 5 to 10% of the general population gets affected with sarcopenia, and globally around 15 to 20% of people get affected with sarcopenia, and various bodies including a Japanese society have also endorsed that about 25 to 27% of their elderly population get affected with sarcopenia. Right. How do we evaluate sarcopenia? Are we going to really screen everyone, going to say that everyone is sarcopenic? No, we are not going to do that. But we will have to have a high index of suspicion, and then that has to be matched with the criteria like the amount of muscle strength, decline in the muscle mass, impaired functional capacity. So you can follow a mnemonic like this, like screening. Whom are you going to screen? There is a specific questionnaire called the SARC-F questionnaire, and like how much of muscle, what is your grip strength, what is your mobility like, whether you are having difficulties in doing activities of daily living or not. So there are a list of questionnaire which is also been endorsed. You can do the screening in that way and say that whether there is probable sarcopenia. So once you establish that there is probable sarcopenia, you then go on for an assessment. In your clinic, you can do the assessment in the form of measuring your hand grip or asking the patient to rise from a chair up to standing position and see how amount of time they are taking. Definitely a person with sarcopenia is going to take a long time for this, and the grip strength is also going to be weak. So you have a suspected sarcopenia, and then you go for confirmation radiologically. Now this comes the difficult part, because we don't have facilities of doing radiological scanning for everyone, like doing a DEXA scan or doing even a better still, doing an MRI scan. And once you have a confirming sarcopenia, then you go ahead in order to prevent it. Like you have to assess then again gait speed, you have to assess that how much of walking speed the person has, how much a person can walk, etc. So the diagnostic criteria, according to the European Working Group, there is a low muscle mass in quantity and quality. Muscle strength is low, muscle quantity and quality, low physical performance are all detected. And there are certain cut-off points according to the various guideline bodies. Like we have a All Asian Working Guideline for Sarcopenia, AWGS, and there is an other, the European guideline, etc. More or less, all of them say that there is a decline in muscle mass. Men have a little bit more higher than the women. Grip strength decreases, and your gait speed is less than 0.8 meters per second, and these confirm your diagnosis of sarcopenia. Are men different from women? Definitely men, postmenopausal women are slightly different from men, because men may get andropause or may not get andropause depending upon how much of vitality or what is your hormonal status you have. So women after menopause definitely get a sharp decline in their muscle mass, and muscle strength decreases early and more rapidly. Neuromuscular junctional integrity becomes a bit disrupted, and therefore because of the hormonal deficiency, and this leads to further functional impairment. So if you look at the physiological changes in the premenopausal women, even if they're obese, it's a gynecoid obesity. The obesity is mainly around the pelvis, and they have got lesser amount of visceral fat, and which again decreases their attribute to the lower insulin resistance in the premenopausal state. But as you pass through menopause, as you have a sharp decline in your estradiol level, the obesity or adipose tissue also changes, and there is more fat deposition in an android disposition, or rather an abdominal fat deposition or visceral adiposity, which contributes to the insulin resistance and also contributes to the declining muscle mass and sarcopenia. So there are certain shared risk factors between sarcopenia and type 2 diabetes. There are intrinsic risk factors which really cannot be changed or cannot be modified, like your advancing age, the amount of oxidative stress that you're carrying in your body, the amount of insulin resistance which is contributed to the amount of visceral fat. You may be obese, you may not be obese. That doesn't really determine your insulin resistance. The amount of visceral fat, the fat around your liver, the fat around your pancreas, that really contributes to their insulin resistance, and that determines that how your metabolism is going to shift from a normal metabolism to being diabetic. Mitochondrial dysfunction you really cannot change, because this has also got something to do with your genes. Mitochondrial function is again genetic, and if you have good genes, then you have a good mitochondrial function. Myosteatosis or deposition of fat within the muscle, amount of inflammation, and low testosterone level. Extrinsic factor, what you can contribute: increase your physical activity, because low physical activity equals to low muscle mass equals to sarcopenia. Sedentary lifestyle again contributes to sarcopenia. Low vitamin deficiency can be replaced. Chronic stress, and of course you can stop smoking. So biological pathway, aging, obesity, inflammation, increased rise of inflammatory factors, increase or derangements of the inflammatory cascade is the cornerstone to the pathophysiology of any of these, all of these metabolic disorders. So your metabolic rate declines, physical activity declines, sex hormone declining, and that is contributing to their insulin resistance, increased amount of adiposity in your blood. Adiposity or adipose tissue is really an endocrine organ, and due to its paracrine activity, increased amount of leptin, decreased amount of adiponectin contributes to increased development of fat in your muscle, and therefore that leads to sarcopenic obesity. So inflammatory drivers, like there is a low-grade inflammation after menopause, which really contributes to all of this sarcopenia. Elevated cytokines like interleukin-6, tumor necrosis factor are all increased, and they really activate the ubiquitin, protease, proteolytic pathways within the muscle, causing increased grade breakdown of your muscle mass. So adiposity means equals to systemic inflammation. Systemic inflammation means increased rise of anti-inflammatory factors in your body, increased decline in your muscle mass because your muscle breaks down. So what about myostatin signaling? Now, myostatin is a thing in your muscle which has got a negative regulator of muscle growth and hypertrophy. So there is increase in your myostatin level, decline in your muscle mass. If your myostatin level can be brought down, your muscle mass is going to increase. And now we are thinking about therapy, especially in the form of monoclonal antibodies, which can actually contribute to reducing your myostatin level and contributing to increase your muscle mass, like stalumabab, domagruzumab, etc., which can really decrease your protein degradation within the muscle and contribute to the growth of muscle fibers. So diabetes with chronic hyperglycemia increases your protein degradation within your muscle, and advanced glycation end product really alters the integrity of your muscle protein, and insulin resistance on top of that alters your anabolic signaling of your muscle, and microvascular dysfunction impairs oxygen and nutrition delivery and contributing to declining muscle mass. So declining muscle mass equals to increased frailty development, increased incidences of falls, increased incidence of fractures, and also activities of daily living gets impaired, and your bedbound, housebound, loss of economical loss, which is personal as well as contributing to the society. So you have a person with sarcopenia. How are you going to assess in your clinic without having it to do with any other test? You can assess their gait speed. If they're walking less than 0.8 meter per second, you can assess their grip strength with the hand grip machine. So grip strength less than 27.5 kg for male and less than 18 kg for female contributes to the, may say that they have sarcopenia. See their calf circumference, and if the calf circumference is low, that indicates that they have lost their muscle, and that can assess your sarcopenia as well. So clinical consequences of sarcopenia: you have osteoporosis, fractures, frailty. Once you are frail, you are bedbound, glycemic control becomes worsens, and things lead to from bad to worse condition. How are you going to prevent? First and foremost, sarcopenia can be prevented with exercise. Exercise, exercise, and exercise. Exercise means just not strolling on the park in a leisurely way and you found your friend during the morning walk, sit down on the bench, have a cup of tea, kemon achen dada, ekটু জিলিপি খাবেন? So that is not form of exercise. Exercise means that you do a form of aerobic exercise to combine with aerobic and resistance training, depending upon your physical capacity, depending upon your age, and ideally a guide should really guide you exactly how much of exercise to do. And it is said that after 60-65 years of age, 3 days of resistance training is enough to preserve your muscle mass and is enough to prevent you from falling. Dietary intervention: we need to increase the protein in the diet. Ideally 1 gram per kg body weight. Indian diet, especially vegetarian diet, does not incorporate a lot of protein. Vegetarian protein really are not that of great degree than animal protein. So you have to think about it, whether you're going to take protein supplements or not, and a trained nutritional specialist will be able to advise about protein supplementation. If you have got vitamin D deficiency, do go actively looking for vitamin D deficiency. If they have D deficiency, supplement with vitamin D, but don't over supplement. I'll have 2 minutes. Don't over supplement with vitamin D deficiency. Vitamin D, hypervitaminosis D can also lead to increased falls and fracture, and that has been recognized in the literature. Energy balance in order to keep up with your weight. Resistance training improves your insulin sensitivity. It helps to improve the glucose uptake in the skeletal muscle. And if you do regular training, your muscle mass is going to improve, and that is going to prevent you from falls and fractures. Nutrition, adequate amount of protein in the diet, because the protein is the only substance that's going to improve your muscle mass. And the protein has to be really of a first class protein, animal protein preferred over vegetarian protein. But if you're vegetarian, then obviously your nutritionist has got to tell you about adding on to vegetarian protein supplements. What about coming up therapy? As I said, that myostatin inhibitors, which are being developed in the form of monoclonal antibodies, and these agents are really going to make a difference in your muscle mass, because myostatin levels are going to come down, and that by bringing down the myostatin levels is going to increase your muscle mass. So targeted therapy like anabolic signaling pathways within the muscle tissue are being developed. These are mainly being applied for postmenopausal sarcopenia. Mitochondrial targeted therapy with antioxidants are another potential source of therapy in order to reverse oxidation at the mitochondrial level and lower ATP levels and restore protein synthesis. Preclinical models of follistatin, which is again a myostatin antagonist, is also being developed, and endothelin 1, which may play a crucial role in myopathy and adipose tissue inflammation, and that is being developed in order to bring down chronic inflammation. So I conclude by saying that type 2 diabetes and sarcopenia goes hand in hand. So an elderly type 2 diabetes patient, be it of a normal body weight, be it of an obese person, think about whether they're having sarcopenia. Advanced aging, insulin resistance, inflammation, oxidative stress, all really contributes to sarcopenia. Few treatments are available for management of sarcopenia, medical treatment available, but again, go for training, emphasize on protein-rich diet, which is the mainstay of management of sarcopenia. Supplement vitamin D if they are deficient, and definitely physical activity plays a crucial role and can really change the balance from being sarcopenic to having adequate amount of muscle mass. Thank you very much for the attentive hearing.
Thank you, Sagarika, for a nice presentation on this very important subject, sarcopenia. Due to lack of time, we are very much sorry that we cannot take questions from audience. That what we learned that throughout the different stages, starting from the adolescence, reproductive period, during pregnancy, during the postpartum period, during the postmenopausal period, and during the older age, the challenges are unique, and we need to address those challenges appropriately, and we need coordinated care to improve the health for women with diabetes. And I want to express my sincere thanks to all the speakers, and I want to conclude the session here. Thank you. Bye-bye.
So now we move forward to a very interesting session on best assist GLP-1. To moderate this session, may I request Dr. Pooja Relia to please carry over with this interesting session.
Good morning, everyone. And we move on to the next session, which is Best Assist GLP-1s. We have a very interesting session, and I would like to start with the tagline, "Aa dekhen zara, kisme kitna hai dam." Once upon a time, metformin was the hero of every diabetic story, simple, reliable, and affordable. Now it is sharing the stage with stars like semaglutide and empagliflozin, and the plot has definitely thickened. So we would wait to see which was the best couple at the end of the discussion, and I would like to invite the chairpersons to come on stage now, please. The chairpersons are Dr. Bhattacharya and Dr. Subhasis Roy Chaudhary. Acha. So I'll request Dr. Sandeep and Dr. Anshan to please come on stage and to proceed further and call our first speaker.
Thank you so much, Dr. Pooja. And I was also looking to this session because this is quite interesting. So much about GLP-1 analogs in the pipeline, so many drugs coming up. And once you start the patient on GLP-1, let's see which drug, as Dr. Pooja said, dekhen kisme kitna hai dam. So we have to see that which is the best assist drug which can be given with uh, this particular molecule. So we have 4 to 5 speakers who would be speaking on the best assist, and maybe in the end we'll be able to finalize or analyze which drug is better when given in combination.
At the outset, I would like to invite Dr. Vinay. He would be talking about SGLT2 inhibitors. Dr. Vinay is a consultant in diabetes at NMS and Santavet Hospital at Ranchi. He is the life member of RSSDI, member of the Endocrine Society, past president of the Rotary Club Ranchi. Over to you, Dr. Vinay.
Thank you. Good morning, everyone. I have removed best. I've just written assist, and I would request the judges to decide which is the best. And with this, I'm going to present the courageous partnership. This is what is the most powerful partnership which we see today is GLP-1 with SGLT2 inhibitors. It's boosting cardiovascular, kidney, metabolic defense. Today in the era of war which we are seeing since 28th of Feb, I think this is the best defense against the cardiovascular disease. People with diabetes die most commonly with cardiovascular disease. People with CKD die of cardiovascular disease. People with MASH die of cardiovascular disease. So the most important thing is if you can actually have a parakram of cardiovascular disease, we have a win-win combination today. And that is why this is the most courageous combination. And a very typical case, what Madam was talking about in the era of semaglutide, more and more generic semaglutide, the affordable semaglutide, GLP-1. This is a very typical case which can be treated very easily today, and not easily in fact, but we can treat these cases very intensively in your clinics and reduce the burden of cardiovascular disease. 42 years, HbA1c 7.8, blood pressure 150/90, comorbidities like dyslipidemia, obesity, coronary artery disease, hypertension, type 2 diabetes, and not to forget in these people, MASH is very common, BMI of 30, history of MI 1 year back, sedentary lifestyle, medication like metformin, rosuvastatin, telmisartan, aspirin, and empagliflozin. So despite modern evidence-based therapies, we have residual cardiovascular risk remains. So this is one area which is very important to address in your clinic when you are actually dealing with obese type 2 diabetics. And the residual risk cardiovascular risks are basically residual obesity risk, residual inflammatory risk. Like Madam was talking in the previous presentation, inflammation is a very key problem. Residual diabetes risk, residual lipid risk, and residual thrombotic risk. So we need to address the residual risk to, in fact, reduce the burden of cardiovascular disease. And at the same time, when you see coronary artery disease, even heart failure has a parallel competitor in morbidity and mortality in type 2 diabetes. So targeting residual risk in CVD patients with dual therapy. Now this is what is very important, that when you add on SGLT2 inhibitors, it will increase glucagon levels. But this is one of the reasons of euglycemic DKA which you see in patients who are on SGLT2 inhibitors. But when you combine it with GLP-1, it reduces glucagon. So it is synergistically highly competent. It decreases insulin levels by reducing insulin resistance, and it increases insulin levels by stimulating the beta cells of the pancreas. It increases urinary glucose excretion. There is a decrease in renal glucose reabsorption, increase in osmotic diuresis, natriuresis is increased. So it decreases the preload, afterload, and the cardiac fibrosis, which is cardiac fibrosis is another very important parameter and responsible for dilated cardiomyopathy, which has been seen in very commonly in diabetic patients. They have normal coronaries and they have no ischemia, but they have cardiac fibrosis, very difficult to treat. Decrease pro-inflammatory adipokines and increase in erythropoiesis. So SGLT2 inhibitors and GLP-1 together, in fact, reduces hyperglycemia, have a low risk of hypoglycemia, and they treat all the 5 components of glycemic pentad: fasting hyperglycemia, postprandial hyperglycemia, they improve significantly HbA1c, they cause very little hypoglycemia, and the glycemic variability is the least with this combination. Having said that, both these drugs are being used even in non-diabetics. GLP-1 been used in obese non-diabetic population. SGLT2 been used in non-diabetic population with heart failure and CKD. So we have evidence of these drugs being used even in non-diabetics. So they are very less likely to cause hypoglycemia, and both of them will reduce your insulin resistance and weight loss. So you can imagine a type 2 diabetes having all the possible pathophysiology are being addressed with this combination. So you cannot have a combination better than this for all your type 2 diabetics. And not only the glycemic pentad, they also take care of both preventing and treating your comorbidities. They prevent heart failure, the combination will prevent heart failure, the combination will prevent renal disease, the combination will prevent MASL, and at the same time, it will take care of the comorbidities like CAD, heart failure, kidney disease. So you can imagine you are treating almost each and every parameters very, very intensively with least possible complications and side effects. So combining SGLT2 inhibitors and GLP-1 in type 2 diabetes, even the guidelines like AD and ESC recommends, both as a potential synergistic effects, like emerging evidence suggests that combining SGLT2 with GLP-1 may have synergistic metabolic effects in patients with type 2 diabetes and even in the kidney outcomes. And stronger together, the power of GLP-1 and SGLT2 in combination more than either alone. So you can imagine there is a 30% lower risk of MACE when you add them together. And there is a 57% lower risk of serious renal events. So you have an additional advantage when you add these drugs in combination compared to when they are being used alone. And someone who is on SGLT2 inhibitors, when you add GLP-1, this again another benefits has been seen in both the categories of drug. So use of GLP-1 and SGLT2 combination is associated with lower risk of MACE and serious renal events in patients with type 2 diabetes compared to each drug class alone. So you can say whether using the class single molecule, do we have beneficial while adding it? Yes, we have benefits. The synergistic benefits that go beyond glycemic control with combination is better HbA1c reduction, better body weight reduction, and better systolic blood pressure reduction. So, and the hazard ratio is very, very significant in all the 3 parameters, which are very, very important. Similarly, in cardiovascular outcome in type 2 diabetes, with both the drugs, class of drugs, we have CV outcome trials, and both of the combinations showed benefit in heart failure, MACE, and all-cause mortality. Even in CKD outcomes, there is robust data. Today, if you see the 4 pillars of treatment in CKD, both the drugs have a single individual pillars in the treatment of chronic kidney disease and diabetes. Reduce incidence of cardiovascular events with combination in people with type 2 diabetes and acute MI. Even in acute MI, if you see, the myocardial salvage is much better off with these combinations than individually. So when you combine, the blue bar is very, very strong, robust data with this class of drugs combination. And not to forget in MASL. Today we are we know there is a very interesting data from the Essence study with GLP-1, especially semaglutide. The phase 3 trial showed robust data as far as resolution of MASH and decrease in fibrosis with semaglutide 2.4 milligram in obese type 2 diabetics. And when you add these drugs like empagliflozin or dapagliflozin, this reduce liver fat content significantly, with some studies showing improvement in stiffness as well. So this combination is very, very robust, and the clinical consideration are like best for patients with mast cell type 2 diabetes and obesity. Even in younger patients, if you start early, they are going to have reversal of fibrosis and mast cell. There is a histopathology data also which suggests there is a reduction in ongoing steatohepatitis. So combination therapy also reduce a reduction in 5-year all-cause mortality when compared directly against either monotherapy. So you have better data when you combine these drugs. The total residual CVD risk and dual therapy, it benefits of adding oral semaglutide in combination with SGLT2 when added to metformin plus minus SGLT2 inhibitor. There is an additional HbA1c reduction, there is an additional weight loss, there is a pharmacological remission achieved with this combination. That is again very, very significant in patients. Today we talk about remission, and one of the mechanism of patients undergoing remission after a bariatric surgery was surge in GLP-1 hormones post-bariatric surgery. So even, and we have data from even obese patients with pre-diabetes undergoing remission with this class of drugs. Even the SOUL trial, which is very, very CV outcome trial, suggested that there was a further 8% reduction in people who received SGLT2 inhibitors along with semaglutide. So you have an additional benefit as far as CV outcome trial is also concerned. Then patients on semaglutide when added to SGLT2 appears to provide more reduction in risk of non-fatal stroke. This is again very interesting because if you see the data from EMPA-REX study, there was an increase in stroke which was seen paradoxically in patients who received empagliflozin, but here you see benefits in stroke as well. So who should get GLP-1, RA and SGLT2 inhibitors? To reduce CV death, to reduce stroke, atherosclerotic cardiovascular disease, heart failure, and CKD. So all these things are very, very robust when you combine this. And as I said, it's a courageous combination, and it gives you a strong defense mechanism against the cardiovascular disease in patients with CKM syndrome. So better myocardial salvage post-MI, then you have a reduction in risk of eGFR decrease of more than 50%, lower risk of end-stage renal disease, then addressing the residual risk, which is very, very important, reduction in MACE and all-cause mortality, and more CVD-free lifestyle years with this combination of drugs. So I thank you all for the patient listening, and I thank the organizers for this opportunity. Thank you.
Thank you, sir. And we'll be taking questions at the end of this session. And I would now like to invite our next speaker, that is Dr. Rahul Bhattacharya, and sir would be speaking to us on thiazole endurance. Sir is a recipient of the Professor Prasanta Sengupta Memorial Medal and Lal Mohan Ghoshal Memorial Medal in Physiology, and is a visiting consultant at Fortis Hospital, Anandpur, Neoto Bhagirathi Women and Child Care Center at Newtown, and Divisional Railway Hospital, Howrah. Sir has contributed to various book chapters on gerontology and preventive aspects of geriatrics. Over to you, sir.
Good morning. So I thank the organizers for inviting me to speak for an orphan molecule, I should say. Now let us start from the pathophysiology. You have seen this slide for 100 times in the past, and it didn't stop there. From ominous octet to egregious 11, treacherous 13, faithless 14. But if you care to look at the chart, you'll find that GLP-1 receptor analogs, they actually cover majority of these underlying code defects, but it leaves major gaps in insulin resistance, whether it's at the level of the muscle or liver or adipose tissue. This is exactly where pioglitazone pitches in. Let me introduce you to Dr. Philip Scherer, and you can easily download this article, The Many Secret Lives of Adipocytes, Implications for Diabetes, which was published in 2019. Because in these days of adiposity, related this A, B, C, D adiposity-based chronic diseases, which is linked to almost 229 diseases, you'll have to understand the biology of adipocytes before you prescribe the drugs for that. And once you read this article, it's a wonderful article which gives you an insight about how adipocytes differentiate, de-differentiate, then re-differentiate, how the white fat turns brown. So once you know about that, it will be very easy to understand and choose judiciously your agents, which will cover the core defects of type 2 diabetes. And of course, the outcomes will be affected favorably. So as you can see, these adipocytes now, they are shown to have interaction with the malignant cells, with the kidneys, everywhere. So once you can take care of this adipose biology, you'll be able to prevent outcomes, including many of these even malignancy. So how does PIO works? Of course, all of you know from our pharma days, it's a PPAR gamma agonist. It binds to PPAR gamma receptors acting as a ligand which activates the retinoid receptor within the nucleus of adipose tissue and other cells. I'll just show you a picture. It is the adipocyte nucleus. You can see the PPAR gamma ligands. And this actually helps to regulate gene transcription, which is supposed to increase the insulin responsive genes. And of course, it will reduce the insulin resistance. It will increase the glucose transporters, both GLUT1 and GLUT4. And it also helps in lipid metabolism modulation at the level of liver, because it has some additional property of PPAR alpha agonism. So that actually helps to improve lipid metabolism and reduce free fatty acids. Now, I'll skip these slides. Now the question is whether the TZDs can cause fat browning. Yes, it can promote adipose browning, but that effect is only modest. Let me be very honest, it is depot specific and probably not the main driver of their clinical benefits. It depends, this fat browning depends on a protein stabilization called PRDM16. And actually there is evidence which shows that PPAR gamma agonists, they can actually stabilize this protein, which actually helps in fat browning. So lipotoxicity is not just too much fat. It is the wrong fat, visceral, ectopic. And only one class of drugs can fix this fat biology, not just fat quantity. So unlike SGLT2 inhibitors, unlike GLP-1 receptor agonists, which work primarily through energy, negative energy balance, weight loss, so that actually cuts down the fat mass. But what pioglitazone does is actually it redistributes the fat, and because it can actually increase the adiponectin levels. It can promote safe fat storage. It just shifts the storage site from liver to subcutaneous fat. It helps reduce the circulating free fatty acids, and of course reduces ectopic fat, which is responsible for all those worse outcomes which we get to see in course of type 2 diabetes. And as I have repeatedly telling you, to read that article by Dr. Philip Scherer, because nowadays adipocytes are no longer seen as an inert storage organ. Rather, it is seen as an endocrine organ with active secretions like adipokines. So you just look at this table. It is the TZDs increases the adiponectin significantly. And of course, it will help to reduce the inflammatory adipokines. No other molecule, whether it's GLP-1 receptor agonist or GIP or metformin or SGLT2, can match pioglitazone in this regard. So does pioglitazone offer anything extra? Because now we are used to buy one, get one free. We have evidence from IRIS trial. All of you know about that because this is the only molecule, oral molecule, which can actually reduce the stroke recurrence. This was a trial which was done primarily in non-diabetic, pre-diabetic population, and we had ample evidence of this reduction in the primary outcome to the tune of almost 24%. And it also helps to reduce the new onset diabetes more than 50%. Now the question, because we know pioglitazone for wrong reasons, the heart failure signals. This is an article which will show you, because it has scrutinized the data of pioglitazone as a cardioprotective agent. There is ample evidence to suggest it causes more than 30% reduction in atrial fibrillation, and you'll be surprised to know many of these studies has actually shown improvement in left ventricular dimensions. I'll come to those. And of course, pioglitazone has a problem with renal sodium handling, which causes fluid retention. But in humans, you can see the beneficial effects at the level of the liver and other agents. Even myocardial ischemia after STEMI, it helps to reduce the infarct size and reperfusion arrhythmias because it takes care of the ectopic epicardial fat. So this is a wonderful imaging study which tried to look at the altered myocardial substrate metabolism. And you'll see the conclusion is PIO was associated with improvement in some measures of left ventricular diastolic function, myocardial glucose uptake, and whole body insulin sensitivity. What about MASH? Because we do not have resveratrol yet, so we have one agent which is approved for biopsy-proven NASH. And how does it start? You know about liver fat. Liver is actually flooded with fat. 60% of that comes from the adipose tissue, which pioglitazone can take care about. And what are the other sources? Of course, de novo lipogenesis, and then from the dietary fat through intestine. So all these will converge, and finally, as a result, the liver will be flooded with fat, whatever name you gave, NASH, MASH. So if you just look at this comparative table, you'll find that PIO can actually, we have evidence of PIO in liver fibrosis, and of course, NASH evidence is quite strong, which we unfortunately do not have for other agents yet. And this is an Indian data from Dr. Vijay Panikar's center, and this is very, very convincing, 25.7% reduction from baseline to 6 months. This is the patients with grade 3 fibrosis. And on your right, you'll find the severity of fibrosis at baseline and 6 months. The patients with F2 fibrosis, F1 fibrosis, F3 and F4, everywhere you'll find after pyotherapy within 6 months, this degree of reduction. This combination actually helps you to fix the core defects as a complementary mechanism to GLP-1. Is it for all? Certainly not. Do you prescribe SGLT2 inhibitor for pyelonephritis? Do you prescribe GLP-1 for pancreatitis? Of course not. If you have a patient with postmenopausal osteoporosis, you won't prescribe this. That doesn't necessarily mean the younger patient, obese patients without these complications will be denied the benefits of such a wonderful molecule, which can take care of one of the core defects in type 2 diabetes, which no other molecule can. So PIO, as Dr. DiFronzo said, is a unique molecule with unique side effects. One can use it judiciously. The cost advantage, I don't need to tell you anything. You know it all. A 10 rupees tablet can actually change the course of type 2 diabetes. So thank you for patient hearing. Think PIO in selected patients.
Thank you, sir. And now I would request our next speaker, Dr. Kirti Suta, to please join us on stage. Could I have the introduction slide, please? Dr. Kirti Suta is a consulting diabetes physician at Dr. Makkar's Diabetes and Obesity Center, New Delhi. And ma'am is also SCOPE certified. Over to you, Dr. Kirti.
So, thank you, chairpersons. And we just had 2 excellent sessions on SGLT2 and thiazolidines. And I'll be talking about metformin. This is going to be my session flow. So I'll be talking about a pathway that is just not complementary, but transformational. We'll be talking from metabolic control to disease modification. Over the last 20 years, we have seen a surge in the number of glucose-lowering agents, but I'll be focusing on metformin, our hero and still the hero, and GLP-1. Various associations have also changed their guidelines, given a place to GLP-1 and SGLT2s. But diabetes management is now more of holistic, person-centered approach. It is managing their weight, sugars, cardiovascular risk reduction, and cardiorenal protection. And this new millennium has brought a new era to the treatment of diabetes. To simplify, we need to reduce the complications also. GLP-1 receptor agonists, they are prioritized for ASCVDs, CKDs, and weight management, but with metformin as the historical anchor. And metformin remains deeply embedded in the treatment of algorithms and real-world patient histories. Now, in one hand, we have our multifaceted multitasker metformin, reduction in hepatic glucose production, increase fatty acid oxidation, increase in enteric glucose extraction, improvement in peripheral insulin sensitivity, decreases gut carb absorptions, and enhances the release of GLP-1 and other gut peptides. Other hand, we have the GLPs, which acts on about 7 out of 8 pathways of the amino octet. GLPs, they don't only give the benefits of glycemic control, but they are also cardiovascular and renoprotective. Not to forget the cardiovascular benefits of metformin, which we have found through the UK PDSN follow-up study. Now coming to the most important part, the complementary mechanism. They are so beautifully complementing each other that they can be the perfect partner. Metformin and GLPs, though they both act at the intracellular levels, but at parallel pathways. Metformin acts at the mitochondrial level, inhibits the complex 1, activates AMPK pathway, while GLPs, they bind to the GPCR, amplifies the CAMP and PK pathway. Hence, 2 different parallel pathways, but giving enhanced glycemic homeostasis, the true additive effects. Metformin also primes the GLP-1 receptor landscape. It upregulates the expression of GLP-1 receptors via AMPK-dependent pathways, increases the receptor density on the cell surface, expands the binding opportunities. So the administered GLP-1s, they encounter a biologically primed environment, hence maximizing their efficacy. Amplifies the endogenous incretin excess. Metformin acts as a mild direct secretagogue of L cells and slightly blunting the DPP-4 degradation also. It suppresses the hepatic gluconeogenesis and enhances the peripheral tissue insulin sensitivity. Metformin dismantles the co-drivers of fasting hyperglycemia, lowers the fasting glucose baseline, prevents the beta cell from operating under constant glucotoxic stress, hence allowing the GLP-1 RAs to act on a healthier, more responsive pancreas. With fasting stabilized by metformin, the GLP-1 optimizes the postprandial control, while strictly glucose-dependent insulin secretion and profound central appetite suppression. So hence, this mechanistic complex matrix is what we get. Metformin acting on the fasting plasma glucose and insulin resistance, while GLP-1s on the postprandial glucose, beta cell function, delays gastric emptying, giving you central satiety. Hence, they both complement each other and eliminate the systemic therapeutic blind spots. Metformin, we have also seen, is the foundation in all GLP-1 receptor agonist trials, not to forget LEADER, SUSTAIN-6, AWARD, and SURPASS. So what we are trying to do is, we are trying to redefine the treatment paradigm from the treatment failure sequential step-up to a proactive synergy. This graph beautifully explains the early combination therapies effect, which yields in good HbA1c reduction and durability that outpaces the sequential step-up therapy. The weight reduction from GLP-1 receptor agonists effectively reverses the lipotoxicity that causes the insulin resistance, which metformin targets. So, do we have any evidence, or we are talking theoretically? Yes, we do have evidence. The 3-year prospective observational study, the DISCOVER study, it beautifully highlighted that treatment with metformin and a GLP-1 receptor agonist was associated with the greatest adjusted weight loss at all points. And the risk of hypoglycemia over 3 years was significantly lower. Not to forget, in the management also, this combination of GLP-1 receptor agonist and metformin resulted in significant reductions when compared to only metformin in terms of body weight, body mass index, waist circumference, fasting glucose levels, and glucose level at 2 hours after OGTT. Talking about the special situations when we have complications, this duo, the renal impairment was significantly reduced in patients who were treated with metformin and GLP-1 receptor agonist. Not only renal, but in cirrhotic patients also. This combination lowers the risk of hepatic decompensation and hepatocellular carcinoma than those on metformin alone. And this dual metformin and GLP-1 receptor agonist therapy had lower risk for both death and hepatic decompensation. They had lower risk of hepatocellular carcinoma also. Obesity, we know, is a major risk factor for a number of diseases. This combination, it helps in patients with type 2 diabetes with reducing the incidence of adiposity-related cancers by roughly 40% and 67% lower mortality with a striking impact on the cancer-related outcomes. In rat model, we have seen the benefits in retinopathy also, GLP-1, liraglutide with metformin. So with any drug comes the side effects also. So do we have any such adverse effects we should be scared of while using these two drugs? No, as such not really, because FAERS database was studied and this pharmacovigilance database was analyzed, and the result was that this combination is superior to monotherapy in reducing severe risks such as lactic acidosis and acute kidney injury. The metformin's insulin sensitization and GLP-1 receptors renal protection underpinned this benefit. And however, gastrointestinal reactions like nausea, vomiting were there. They were the concern areas. So how to deal with that? I slipped it, sorry. So I'm so sorry. So how to deal it was, you have to set up with the dose of metformin first, then start with the, I need to have my slides, the last slide, excuse me, the last slide. So we have to stabilize the dose of metformin so that the microbiome, the gut is stabilized as per it, and then we need to start with the GLPs so that to minimize the side effects. And the data in Asian populations, what we are worried of, because we are Indians, so before using any combination or any drug, we need to know what we are, actually we will be dealing in reality, real world. So in Asians, we get the best outcomes in terms of reduction of HbA1c and visceral fat. And to just summarize, I'll say, let's take this duo together from a perfect couple, from a companion to a partner. And thank you. And please block your dates for Dr. Makkar's upcoming conference, ACCD, going to be on 15th and 16th August, Delhi. Welcome you all over there. Thank you.
Thank you, Dr. Kirti.
I'm so sorry for the confusion which got created.
Our next speaker is Dr. Vikas Bhattacharjee. He would be talking about addition of the GIP agonist to the GLP-1s. Dr. Vikas Bhattacharjee is the director and a senior consultant at the Sun Valley Hospital, Guwahati. He was the past executive member of the RSSDI East Zone, currently Joint Secretary IRO, and Vice President of the NETS, past chairperson RSSDI Assam chapter. Over to you, sir.
Thank you, sir. Thank you for kind introduction. It is always wonderful to come to Kolkata for its artistic, cultural, and scientific ambience. And I thank Dr. Shivapratik, for inviting me. So my topic is GIP agonist as an assist to GLP-1. I think between GLP-1 and GIP was much before discovered than GLP-1. And we know that it is a nutrient-stimulated gut hormone, along with first GIP is secreted from K cells, then GLP-1 is secreted from L cells. And there is 42 amino acid peptide hormone. And thing is that although it was discovered long back, somehow its interest to the GIP got dampened. And for this study it happened. Effect of porcine gastric inhibitory polypeptide on beta cell function in type 1 and type 2 diabetes mellitus. It was done long back in 1987. So in that study, porcine GIP was infused to the normal subject, to the NIDD, of course, that is the type 2 diabetes, and IDD, that is the type 1 subjects. And C-peptide concentration was measured before, during, and after infusion of porcine GIP. And what was the result? We found that in normal person, there is a huge increase in C-peptide. So there is insulin secretion was significant. But very little increase in NIDD, that is the type 2 and type 1. And that dampened all the spirit. And for that reason, in a publication from 1987, deep down. And there was a study to show this in 1993 that GLP actually increases insulin secretion. So there was a huge increase in the publication. So that's what happened. But there was a study, and that saved GIP. And that was shown that after 4 weeks of intensive insulin therapy, there is increase in GIP along with GLP-1. So then again, interest started growing. GIP is derived from 153 amino acid protein circulating as a biologically active 42 amino acid peptide. The GIP receptor is a class B G protein coupled receptor expressed in pentasic beta cell, adipose tissue, bone, interestingly bone, and central nervous system. GIPR activation leads to cyclic AMP production, PK activation, and downstream signaling of insulin secretion and cell survival. GIP is rapidly secreted postprandially with plasma levels rising from 10 to 20 picomolar to 80 to 150 picomolar after a meal. And that stimulates insulin secretion in a glucose-dependent manner, accounting to 60 to 80% of the postprandial insulin response in healthy individuals. So in healthy individuals, it is the dominant incretin. And it promotes beta cell proliferation, survival, enhances lipid storage in adipocytes, and modulates bone metabolism. GIP also influences glucagon secretion. In fact, it's so important that hypoglycemia increases glucagon secretion. So it regulates it. But in hyperglycemia, it is glucagonostatic, doesn't increase it. It causes appetite regulation and may affect cardiovascular and neurocognitive function. In type 2 diabetes, GIP responsiveness is diminished, contributing to impaired incretin effect. GIP agonists bind to GIP receptor, activates G-alpha subunit protein, stimulates adenyl cyclase, increasing cycling AMP and activating PKA and EPAC2. This cascade enhances insulin granule exocytosis, beta cell survival, and may promote beta cell proliferation. GIP activation in adipocytes increases lipoprotein lipase expression, facilitating triglyceride hydrolysis and fatty acid intake. But chronic GIPR agonism may induce receptor desensitization and internalization, potentially leading to functional antagonism in some tissues. So that is important. We'll talk about that also. So here you can see how it happens, GIP receptor signaling, GIP binding to GIP receptor, and there is activation of the G-alpha S, and then there is increase in cyclic AMP and exocytosis and everything happen. On the other side, there is recruitment of beta-arrestin, and that increases internalization and recycling and degradation. So two things happen. When there is antagonism, we'll hear about that later on, there is total antagonism and there is no signaling. But I talked about chronic GIP receptor signaling, and there what happens when there is chronic stimulation, there may be, and it is a very strong hypothesis, there is increased beta-arrestin recruitment and internalization and desensitization to the agonist. So that may happen. So long-acting selective GIP receptor agonist has been developed, and one of them is mecupetide, and it has got some studies. I'll show it. And it is a 12-week study. One arm was dulaglutide, 1.5 milligram, and then another arm mecupetide 20 milligram plus dulaglutide 1.5 milligram, and another arm is mecupetide 20 milligram. And examine individual and combined effect of mecupetide and dulaglutide on body weight and glucose control, clamp-derived insulin sensitivity, insulin secretion, and clamp disposition index. Let us see what is the result. Mecupetide lowers body weight in individuals with type 2 diabetes and augments the efficacy of dulaglutide. So here, this assist effect, we can see that there is increase in lowering the body weight when it is combined to dulaglutide. And you can see the weight reduction. It was significantly increased from 3.8 to 6.2. Mecupetide lowers glucose in individuals with type 2 diabetes, significant glucose lowering alone, and there is small augmentation is there with dulaglutide. So from there you can see the assist that happens, it really occurs. Mecupetide increases insulin secretion and insulin sensitivity, significant effect alone and augmentation effects on dulaglutide. You can see there insulin secretion with combined, it is much higher than mecupetide alone, and also insulin sensitivity also has increased quite significantly. So it is really assisting the GLP-1 dulaglutide. Now we are coming to the molecule, a wonder molecule we are using now. The proposed roles of GIP and GLP-1 in regulation of metabolism. GIP activity central nervous system reduce food intake, decrease nausea. Whereas GLP-1 reduce food intake, increase satiety, and increase nausea. That is very, very important thing. Decrease nausea and increase nausea. GLP-1 doesn't have any effect almost, don't know exactly, on adipose tissue, but it has got huge effect on adipose tissue. Increase insulin sensitivity in adipose tissue, increase lipid buffering capacity, increase blood flow. That is very, very important because that moves the substrate inside and there is adipogenesis. Increased storage capacity is there, and as a whole there is a reduced inflammatory immune cell infiltration. So what it does actually, it makes non-functional adipose tissue functional, and that is very, very important. That is not done by GLP-1. In the pancreas, there is increased insulin secretion and increased glucagon in a glucose-dependent way. That is, when there is hypoglycemia, there is increased in glucagon. This is a wonderful thing. So it has huge effect in lowering hypoglycemia. In pancreas, GLP-1, we all know that increased insulin secretion and reduced glucagon. And stomach, very importantly, delayed gastric emptying. So these together can do really wonder. Tirzepatide is a single molecule designed to activate both the GIP and GLP receptors. It is based on native GIP-1 sequence. Receptor activity on the GIP receptor is similar to the native GIP hormone, whereas the activity of GLP-1 receptor is lower compared to the native GLP-1 hormone. So it is a bit imbalanced. Mean half-life is approximately 5 days. That is, for 1 week, we can use it. And there is no dose adjustment for renal and hepatic. This is a good thing. And there is a reconciling mode of action of dual GIP-1 and GIPR. I have talked about it. I talked about it is also that tirzepatide is imbalanced and biased dual GIP and GLP-1 receptor. Now, why it is GLP-1 bias is that there are two pathways I have showed. One is amplifying pathway and another is the beta-arrestin pathway. Now, here is more stress on beta-arrestin pathway. So that's why GLP-1 remains in our circulation for longer time and probably acts for longer time. So it is a bit biased. Now, this slide you have all seen. It is nothing new. The wonderful effect, surpass 1, surpass 2, surpass 3, surpass 4. Lowering is around 2.5 to 2.6. So it is a great thing. And it has done wonderfully well compared to semaglutide, even the lowest dose. Sorry. And what is the effect of GIP, if you can see that? Clamp disposition index, insulin secretion and whole body. If we deduct the effect of GLP-1, that is semaglutide, then you can find the effect. And you can definitely see the clamp disposition index also. There is significant effect of GIP in total insulin secretion and also whole body weight insulin sensitivity. So GIP is really assisting properly GLP-1. And this is the weight reduction. It's a wonderful weight reduction. I don't have to show that. We have seen hundreds of times. And there is huge reduction. And probably that becomes possible for one thing. It has got inhibitory effect on the emetic MSs. That is the emetic center. It has got an effect. Because those neurons that expresses GIP, they are GABAergic signaling give and they inhibit MSs. So this is a good thing that tolerated dose goes much higher and so we can attain higher weight loss. And from this chart, you can see that it is compared to anyone. Although it is not translated in a big way, this is the least nausea and vomiting compared to, your semaglutide or cagrilintide. It has got the lowest one, vomiting and nausea. Now the last slide only. I think this is a comparison between cagrilintide and tirzepatide. It has just come out, which is better, because we don't have any problem with metformin, we don't have a problem with SGLT2 inhibitor, we have no problem with pioglitazone. They are the essential combination. So they will definitely assist. But there will be some complication with cagrilintide, and there you can see it has proved that cagrilintide is not inferior to tirzepatide. This is the latest thing. So still now it is the best assist. Thank you very much for your kind listening.
Thank you, sir. We'll take the questions at the end, sir. So moving forward, we'll do a slight shift. We'll ask Dr. Selima to please come up next, and because she'll be talking in continuation on GIP antagonists. Could I have the CV slide for Dr. Selima, please? Ma'am is a DM in endocrinology and is attached to the Medica Super Speciality Hospital and TMC Kolkata, has publications in various national and international journals, and is a speaker and panelist in various conferences, and is also an author of chapters in textbooks. Over to you, ma'am.
Good morning, everyone. At the very outset, I would like to thank the entire organizing committee of EMOCON for the invitation. Thank you, chairpersons. So I have been entrusted to speak on the session GLP-1 Best Assist, and my topic being GIP antagonist. So my job has been already done much easier thanks to my previous speaker, Bhattacharya sir. So there'll be a lot of overlap in this session as well. Now coming to the unmet needs of people with obesity. So we all know that from the advent of the GLP-1 antagonists, it has transformed the care of patients living with obesity and can also help us in managing this global health issue. Though we have come a long way with the improvement, with the steady improvement in the efficacy of these molecules, that is the GLP-1, but still there is scope for more and more inventions and more therapeutic interventions which can help us in reaching out to a greater number of individuals. So coming to the efficacy, of course, we already are having good efficacies, but coming to the administration frequency. So previously we had the exenatide, which was twice a day. Then we come to liraglutide, which was once a day administration. Now we have semaglutide, which is once a week. But then even longer acting agents are desirable. Coming to another issue, that is rapid regain in weight after discontinuation. This is one particular issue which I'm sure all of us are facing, and we need to know whether there are agents who can help us combat this. Last but not least is the persistent GI adverse events. So we would need a molecule to be combined with the GLP-1 antagonist who would help us in tackling these challenges. So coming to the GIP receptor, which has been previously discussed by my previous speaker. So what is this? It's glucose-dependent insulinotropic polypeptide. And the issue, the story around this GIP was actually rather simpler multiple years back. But in the last couple of years, it has led to a lot of topsy-turvy. Why? Because we have GIP receptor agonists and we also have the GIP receptor antagonists. Agonists are stimulating the receptor and antagonists are inhibiting the receptor. But if you look at the diagram, then either if we combine the GIP receptor agonist with the GLP-1 receptor or the GIP receptor antagonist with the GLP-1 receptor, both are going to lead us to achieve improved glycemic control as well as weight loss. So how is it possible that the same molecule is going to act via two different mechanisms and bring about the same effects? For that, we need to just briefly go through the physiological actions of GIP, also at the molecular level, and the evidences that we have in this regard. So like my previous speaker, sir, has already mentioned that GIP is secreted from the K cells of the small intestine, and it is released in response to food consumption, whether it's a high fatty meal or carbohydrate meal. And since it has a very short half-life, it is inactivated by the DPP-4s. What is its purpose? Basically, once the GIP is activated, it brings about glucose-stimulated insulin secretion from the pancreatic beta cell. It also stimulates glucagon, which is contrary to the GLP-1, which suppresses glucagon. And it also increases blood flow or blood circulation in the adipose tissue and gut. So why is this important? Is because if we look at the actions of GIP-1, it is rather a obesogenic hormone because it is increasing blood circulation in the adipose tissue. It is leading to deposition of fat, deposition of triglyceride. It is causing absorption of nutrients. So for all practical purposes, if GIP, glucose-dependent insulinotropic polypeptide, is increasing the lipid deposition, it is actually causing weight gain. So it is actually natural that if we are using a GIP antagonist or we are blocking it, we are going to have weight loss. So what are the evidences that we have in this regard? So here if we look in these GIP receptor knockout mice, so most of the data that we have are belonging to the murine studies. So here in the GIP receptor knockout mice, it was shown that whenever we are feeding them with a high fat diet, they are having no weight gain. So this was indirectly an evidence which showed that these animals were protected from the effects of diet-induced obesity when they were placed on a high fat diet. Now these are again of murine studies and it is making sense. So if GIP receptor antagonists are helping us in losing weight, what is GIP receptor agonism? We have agents like tirzepatide, which was discussed by Bhattacharya sir, that it is a GLP-1 and GIP receptor agonist. How is it going to work? It has shown weight loss to the tunes of 20% or even more. We have the next generation retatrutide, which is again a triple receptor agonist. That has also shown to have weight loss. So both agonists as well as antagonists are showing weight loss, and we have evidences in favor of agonism. So let's have a look at whether we have any evidence in favor of GIP receptor antagonism. So I'll be just brushing through in a bit details. In 2021, a molecule AMG-133, which is a combination of GIP receptor antagonism and GLP receptor agonist, was presented. It is a human monoclonal anti-human GIP receptor antibody with GLP-1 agonist. In preclinical efficacy studies in diet-induced obese mice as well as monkeys, this showed reduced body weight and improved metabolic parameters to a large extent than a GLP-1 receptor alone. So then comes in maritide. What is maritide? It is maridebart cafraglutide, where cafraglutide is standing for the GLP-1 component and maridebart is for the GIP antagonist. So it's a GLP-1 plus GIP antagonist. We have gone through the phase 1 trials as well as the phase 2 trials, but the phase 3 trials are pending. In phase 1 trial, here it has shown an acceptable safety as well as tolerability profile with no difference between the treatment groups in terms of clinical safety lab parameters. Most common adverse effects are GI, which are very mild, nausea, vomiting, and can be resolved within 48 hours. In the phase 1 studies, the dose-dependent weight loss was shown to the tunes of 14.5%. and it reached maximum concentration in about 4 to 7 days. Coming to the phase 2 trial, which is having 2 cohorts, that is the obesity cohort and the diabetes cohort. Here, the maritide was given in varying doses between 140 milligram, 280 milligram, 400 milligram in varying doses also. It was given once in a month, and sometimes in some areas it was up-titrated, in some portion of the studies it was not up-titrated. That was in the obesity cohort. We have shown a mean percentage change in body weight from baseline to week 52 to about 12.3% to 16.2% versus 2.5%. Coming to the diabetic cohort, we also had similar findings. It was 8.4% to 12.3% weight loss versus 1.7% in the non-arm. So now I've just kept this slide as an extension to why is it that both GIP agonists as well as GIP antagonists are helping in losing weight when they're combined with the GLP-1. So there is the first theory of biased agonism. That is, when these agonists and antagonists are tied to the receptor, they're going to work through different channels. So biased agonism means a particular pathway is being handpicked, which is going to promote weight loss, and the other ones are not being stimulated to that extent. Secondly, which again sir has mentioned, is chronic GIP receptor stimulation leads to functional antagonism. When we repeatedly go on hammering the receptor with an agonist and it's chronically stimulated, it actually ends up becoming a functional antagonist. Last but not least, there is another hypothesis which states that GIP receptor agonists and antagonists act on different population of receptors, both in the CNS as well as in the periphery. So this slide also has been discussed by my previous speaker, but just I have kept it to summarize, is when the GIP receptor comes, GIP molecule comes and binds to the receptor, which is a G protein coupled receptor, it gets activated and it leads to conformational changes in the receptor, where it leads to activation of adenylyl cyclase, leading to increase in cyclic AMP, activation of protein kinase C, and the pathway is completely going on and on. Here, a very important aspect is the beta-arrestin. The internalization of beta-arrestin is very important because we'll be discussing later today, we don't have that time, that there are some genetic mutations where if the G protein coupled receptor is mutated or there is some missense mutation in the beta-arrestin component, then those particular individuals are shown to be resistant to obesity. That is, they do not gain weight despite eating more and more or exercising less. So this is very important. Another is the picture, which is the image number C here, which I have just discussed, that if we continuously go on stimulating a receptor, then it is going to lead to functional antagonism. So what is the rationale for GIP receptor antagonism in the treatment of obesity? First of all, GIP is obesogenic. GIP receptor activation leads to nutrient absorption, lipid deposition, and adipose tissue blood flow. Coming to the murine evidences that we have, blocked or reduced GIP receptor function is anti-obesogenic. Last but not least, the agent maridebart cafraglutide, or maritide in short, is in pipeline where phase 3 studies are going on, and up to the phase 2 clinical trials, it has shown significant weight loss in the treatment arm. So to conclude, together, the obesogenic role of GIP, human genetics, preclinical data and emerging clinical trial data point to the potential of GIP receptor antagonist to complement GLP-1 receptor agonism in helping people living with obesity achieve healthy goals. Thank you very much for your patient hearing.
Thank you, Dr. Silima. Our next speaker would be Dr. Arun Shankar, and he would be talking about amylin analogs. Dr. Arun, please. Dr. Arun is the Medical Director and Consultant Diabetologist at the Jyoti Dev's Diabetes Research Center, Trivandrum. He is the Chief Coordinator of the Diabetes Telemanagement System there, and he is the Secretary IMA and NEMGOM. And he is an investigator in the various clinical trials involving liraglutide, semaglutide, degludec, and icodec. So, over to Dr. Arun, please.
Good morning, respected chairperson, senior physicians, diabetologists, endocrinologists, and my dear friends. At the outset, let me thank my dear friend, Dr. Supratik, and the entire team of EMOCON for giving me this opportunity. Last year, unfortunately, I couldn't make up for the conference because of my health issues, but this time I made sure that I'll be attending the conference. And today, I'm standing here not with that much data to support the topic which I am dealing with, that is amylin. But of course, we have heard so many things about the existing molecules in combination or to assist the GLP-1 agonist, which is the highlight in these days while managing diabetes. So I'll briefly cover the molecular structure of amylin, its receptors, physiological roles, and central mechanism in appetite regulation, and finally the combination effect of GLP and GIP, how it is going to help your diabesity, the more number of obesity and diabetes, the patients which we are coming across these days. So what is amylin? Amylin is a 37 amino acid neuroendocrine peptide co-secreted with insulin from pancreatic beta cells in response to meals. It has a very short half-life of about 15 to 20 minutes, and definitely it plays a key role in postprandial glucose and appetite regulation. See, here it clearly shows that the relationship between amylin and calcitonin, both peptide belonging to same family but with limited similarity in their amino acid sequence. But calcitonin, you can see a 32 amino acid polypeptide hormone that is being secreted by thyroid, which helps and has a role in calcium and bone metabolism. But the calcitonin receptor has a major role while we discuss about amylin per se. So coming to amylin receptors, they are complexes of calcitonin receptor with receptor activity modifying protein. And there are three main subtypes of receptors, that is amylin 1, amylin 2, and amylin 3, with amylin 1 and amylin 3 being most functionally relevant in the case of diabesity, and the biological function which is being highlighted there. And the amylin which is going to bind is via the C terminus and activates in the receptor through its N terminus. So the structure, the amylin receptor affinity, it is clearly being highlighted earlier itself. The amylin receptor 1 and 3 has having high affinity when compared with the 2, and amylin docks to the receptor via its C terminus. The N terminus then binds to the extracellular loops of the receptor and triggers receptor activation. So amylin actually exerts multiple effects including slowing gastric emptying, suppressing glucagon, and of course regulating appetite through central pathways, especially via the area postrema. But there are two phases of amylin. You have to be very careful. One of the most interesting aspects of amylin is its dual nature. In its physiological form, it plays a beneficial role in metabolic regulation. However, under certain conditions, as you know, especially in insulin resistance, we can see amylin can aggregate into oligomers and fibrils. This pathological form contributes to beta cell dysfunction. Again, this duality has been described as Dr. Jekyll and Dr. Hyde phenomenon. So amylin has two phases which has to be taken care. And coming to the particular action of amylin, that is the area postrema acts as the primary activation center for amylin, and activation here triggers the downstream neuronal signaling leading to reduced food intake and having an anorectic effect. When you are combining with the GLP molecule, ultimately resulting in the benefit of having reduction not only with the glycemic control as well as weight reduction and the other advantages which we are going to see with the other studies going on and the pipeline molecules among the amylin group which we are going to have in future. So amylin signaling involves multiple brain regions as shown earlier, including nucleus tractus solitarius, arcuate nucleus, and reward centers like the nucleus accumbens and ventral tegmental area. So the peripheral amylin acts primarily on the area postrema and the arcuate nucleus. The signals from these regions propagate to higher centers controlling appetite and reward. So the signaling happens in the area postrema, largely mediated by the RAMP1 and 3 receptors, which was highlighted earlier itself. This is crucial for its appetite suppressing effect of those 2 receptors when we discuss particularly about the amylin receptors per se. And it has shown that amylin signaling in the area postrema is mainly dependent on these receptor activation. And you can see the red stain indicates increase and in activity and the blue stain having decreased activity. And amylin signaling in the ARC modulates long-term energy homeostasis, activate POMC in the ARC and downstream PVN, potentially could impact long-term thermogenic effect via modulation, and amylin impact on energy expenditure needs further investigation. That's what I said. These molecules, still we have to get the data, then only we will be able to know the exact advantage of using amylin along with GLP, which has almost a synergetic action ultimately helping in diabetic individuals. So not only that, amylin enhances leptin sensitivity. This synergy is important because leptin resistance is the major concern in obesity, which we are seeing in obese diabetes individuals. Amylin helps to restore leptin responsiveness, improving weight regulation, and leptin and amylin appear to have a synergistic effect on food intake. Peripheral leptin and amylin binding to the arcuate nucleus and activation of downstream pathway appears to be in part responsible for the physiological effect. And amylin and leptin interact across multiple brain regions including AP, ARC and all those centers, producing additive effect on appetite suppression and energy balance. So this is the summary of proposed primary and secondary brain activation pathways by amylin. That is the area postrema as well as the arcuate nucleus. Overall, amylin acts through both these primary and secondary pathways involving brainstem and hypothalamic circuit, influencing both homeostatic and the hedonic eating, which we discussed when we come across the diabesity. So amylin reduces meal size and energy intake while also modulating reward-driven eating. It impacts both homeostatic hunger and hedonic craving. So first approved analog, amylin analog was pramlintide, used along with insulin, but the limitations were short half-life and multiple injections needed. Coming to the newer generation analogs, as already discussed, cagrilintide, the molecule in pipeline, still not available. Among the audience, I am sure those investigators who are part of the clinical development program with regard to amylin, that is the clinical trials ongoing with the usage of cagrilintide, they might be knowing the exact advantage of how it is going to help when you are going to combine with the GLP-1 agonist. And other being petrelintide and loralintide. So these new generation analogs, definitely along with GLP, they are being used as once weekly injection. Coming to cagrilintide, it is again long acting once weekly preparation, and the weight loss in the clinical trial, it has shown up to 11% with 26 weeks phase 2 study. And of course the common side effects or the adverse events which we have come across with the usage of amylin per se is definitely with regard to gastrointestinal events seen. And coming to petrelintide, there again it is long acting, having a T-half of 10 days, and weight loss in the phase 1 trial, it has shown up to 8.3%. And coming to loralintide, there again once weekly preparation, but the weight loss was up to more than 20% with 48 weeks phase 2 study. Again, the adverse event dose-dependent nausea, the gastric symptoms which we have come across while using these molecules. So coming to the main molecule among the amylin, which we have some data, the physical, phase, different phase studies with caglitide, what we have seen, that is caglitide is having a 84% homology to native human amylin. And the purpose of the amino acid substitution and acylation were primarily to remove the fibrillating properties of human amylin and ensure its stability. And T-half approximately got up to 180 hours. That is why it is being used as once weekly preparation. So the caglitide increased neuronal firing in hypothalamus that was observed, and caglitide activates regions of the brainstem involved in food intake in rats comparable to mice. Again, these are the observation with regard to the amylin molecule. And the potential combination or the benefits which we are going to get with the combination of GLP. Again, in the diabesity, we are not only aiming to have a better glycemic control, weight is also being addressed with the combination. So ideal one to combine with GLP, again, you have the option of going just for a once weekly injection rather than going to combine with any other oral agent. So SEMA, that is GLP, when compared with the caglitide, having the benefits of better weight reduction and blood sugar control. So the next generation analogs, amylin analogs, that is the DACRA's dual receptor agonist, having longer half-life, weekly dosing potential ability is being used, and all these clinical development program, phase 1B, phase 2B, all these trials with regard to the usage of CagriSema, it has shown the benefits while not only addressing the glycemic control, weight reduction, and other inflammatory markers being reduced with the usage of the molecules. So again, the evidence of from the meta-analysis, it has shown that superiority of CagriSema versus monotherapy. I'm not going to detail the amylin targeted pharmacotherapies which are again in pipeline. All those amylin molecules you can see. And luckily, we were also part of the upcoming, the yet to be declared results, the clinical trial with CagriSema, caglitide and semaglutide combination. And the take home is, while using amylin-based therapies, the physiology, of course, amylin being co-secreted with insulin, it is critical for glycemic control and appetite regulation. And of course, like what I said, the long-acting analogs in the amylin group is having a beneficial role while using along with GLP, will be assisting in diabetes control and weight reduction. But at the same time, we need to have the safety data while using amylin, including the cardiovascular safety data, which is to be needed, utmost importance while managing diabetes. And the challenges, of course, the subcutaneous administration, once weekly preparation, GI side effects, which we are again seeing with all those GLP, GIP, and of course with amylin usage. And future, definitely non-injectable formulations will be coming with the amylin preparation. So without injection, we will be able to tackle the condition. So to conclude, amylin analogs are emerging as a central strategy in obesity as well as in type 2 diabetes management, where glycemic control and the diabesity per se is being addressed with the potential to reshape metabolic therapy through multi-hormonal mechanistic approaches involved in diabetes management. So with that, with the permission of organizers, I would like to invite you all for the Jodev's Professional Education Forum 14th Annual Global Diabetes Convention on 10th, 11th and 12th July at Uday Samudra, Trivandrum. And you can send the abstract. The abstract submission is still open. Thank you.
Thank you, sir. And I've been told by the organizers that due to lack of time, we will not be taking any questions. So I leave it to all to decide which is the best jodi, and we go henceforth from here.
So thank you, moderator, chairperson, and speakers for the excellent session. Now it's time to hear from the stalwarts. To chair this session, may I request Dr. Pooja Relia, madam, to please come over. Dr. Arun Shankar, sir, and Dr. Ritesh Sharaugi, sir, to please come on the chair. And to start the session, keynote lectures by introducing our stalwarts.
Good afternoon, everyone. As we start the keynote lectures, I would like to request our first speaker to come, Dr. Shashank Joshi, sir. Okay, so we would go first to Dr. Samit Ghoshal, and sir would be speaking to us. Sir would be speaking to us on inching close to precision and the anti-obesity pharmacotherapy. Sir is a visiting professor at University of South Wales and has been a consultant physician at Nightingale Hospital. Over to you, sir.
Thank you. So my talk is how to choose anti-obesity medications. As of now we have just two medications. We have semaglutide and tirzepatide. Next year we're probably going to get orforglipron, we'll get cagrisema. Now how is the choice of medicine going to be? You just put someone on one, wait for 3 months, doesn't work, then put them on the other drug, or there are some specific ways of choosing them. Now here are some stats to tell you that when you initiate a patient, you tell them that this is a molecule which is going to help you lose weight. Can you guarantee them they're going to lose weight? Because these are all from the STEP trial programs, around 15 to 16% of your patients will not lose weight. At least not the desired amount of weight loss, which is 5% from baseline. Now there's no way of preempting this. We might say these are excellent agents, some of you will lose around 15-20 kilograms. But is the patient going to lose that? Again, we don't know. Now this is the overall data, not from STEP, but from other trials done with other molecules. So you see the non-responder rate can go up to 32%. So 1/3 of your patients will practically not respond to this therapy. The way we have been choosing these molecules now are based on regression-based statistics, which tells you that this is our own data in the Obesity Society, of the USA, where we presented and shown that type 2 diabetic patients tend to have a blunting of anti-obesity effect. So if you are saying that you're going to lose weight, I'm putting you on a semaglutide. Probably if the patient is non-diabetic, he's going to lose the desired amount of weight, but there'll be a blunting of effect in type 2 diabetic patient. As you can see, with dual agonists, you see a gap of 5 kilograms, with GLP-1 around 4, but this gap is reduced with retatrutide. So with retatrutide, probably will be safely be able to say that the weight loss is similar between diabetic and non-diabetic population. These are the other ways of predicting who are going to respond or not. Females are supposed to respond better than males. Age, obviously, as you keep on increasing in age, your BMR goes down, so your chance of success goes down also. But if you see, these only account for 21% of prediction of weight loss. The vast majority of predictions are unknown to us, and we need to explore and find out what are them. So I am going to present a hypothesis from my end. It is under review now in the World Obesity Society. So this is something that a hypothesis that I am proposing, which is phenotype based. I will end with the absolute precision based decision making, which is genotype based. Now, GLP-1 has an activity level at 3 different areas. If you put someone on insulin, there is only pharmacokinetic and pharmacodynamic. That's absorption from the skin and effect at the receptor level. But GLP-1 has 3 different areas. Apart from PK/PD, there is also a level which is the central nervous system where it works, the area postrema. Now, at the level of subcutaneous tissue, the obese patients have an increased expression of collagens. So there are a lot of fibrosis. And that's why you find for a lot of patients who are extremely obese, when you inject them with the drug, the absorption is erratic. So the response will be blunted. Secondly, it goes into the system through the lymphatic system. There's increase in viscosity in obese patients. And again, the more obese they are, the more viscous is the lymphatic system, and the more erratic is the absorption. In the backdrop of type 2 diabetic, there's an increased expression of the enzyme DPP-4, which breaks down the GLP-1 molecules, although we have a protective mechanism in place, but it still can be broken down with higher concentration of DPP-4. And remember, a molecule like semaglutide acts through the fatty acids linking chain that it binds with albumin and works. In diabetic patient, you have glycation of albumin. So the binding sites might not be available for GLP-1. So these are pharmacokinetic determinants. This is genomic, so I'll not go deeper into it. A lot of your patients may have the receptor polymorphism, receptor at the level like GLP-1 receptor, GIP-1 receptor. If those polymorphisms are there, it's not that patients will be non-responder, but there will be blunting of response. The final area is the brain. And in the brain, there are two distinct areas which tackles this weight loss issue. One is the area post-trema, where you have the satiety center. Now, if you see your patient coming with a bunch of reports, and if their ferritin is high or the CRP is high, they have a high inflammatory process going on. They might have microglial fibrosis, which will prevent the satiety center from getting effectively regulated by your GLP-1 enzyme. So that can also blunt your response. So you have your patient coming and telling you that this is the appetite or hunger-based phenotype. I feel very hungry, I eat more, and hence I gain weight. So the automatic choice will be a semaglutide, because that takes care of your satiety. But in spite of give them adequate dose of semaglutide, your patient might still tell you, "Doctor, ekhono khub khide pacche." This is where the mesolimbic system comes, the reward pathway. So even after taking care of the satiety center, if your mesolimbic system is hyperactive, the dopamine will be high, and in spite of giving them GLP-1, the patient will feel hungry and keep on eating. So how do you tackle that? So I'm proposing that we have two distinct ends of distinct phenotypes with a lot of overlapping pattern. One end is the appetite-based or hunger-dominant phenotype, when the patient comes and says, "I'm hungry, I'm eating more and gaining weight." The other phenotype, which is the metabolic insulin resistance, low BMR phenotype, where the patient says, "I'm actually eating less," which is true, but is still gaining weight. And we have a significant overlap between the two phenotypes. This is the diagnostic dashboard that I'm proposing. Before starting any patient on weight loss therapy, ask them a simple question: do you feel hungry and hence eat more and gaining weight, or you're not eating more and you're still gaining weight? Two, look at the inflammatory markers, look at hsCRP, look at triglyceride HDL ratio, look at skin tags, look at acanthosis nigricans, look at HOMA with fasting insulin and see whether they're predominantly insulin resistant. And look for ectopic fat deposition. The easiest way of doing that is doing a FIB4 and then doing a transient elastography looking at the MASLD. So if you have this dashboard, then you can choose which phenotype we are talking about. So this is the algorithm which I am proposing. If your patient is the hunger type phenotype, put them on a GLP-1 like semaglutide. If they say we are still hungry, then this is an ideal candidate for amylin, because amylin takes care of the mesolimbic system, which is cagrisema. So in future, when we'll have a cagrisema, patients on semaglutide still feeling hungry, this is the ideal candidate for cagrisema. So you see, we are now choosing molecule based on the phenotypes. But if your patient is not eating more, gaining weight, you can use the Herrick-Benedict equation, a simple thing using your phone, telling you how the BMR is. If the BMR is low, you need to burn more energy. This patient needs a glucagon agonist. So when retatrutide is going to come, these patients will be fit for retatrutide. If the BMR is fine, but has significant abdominal obesity and insulin resistance, this patient is fit for a dual agonist, GLP-1, GIP. So this type of algorithm will help us in identifying patients in advance using phenotype. But it is still not foolproof, because the second area which I showed, the receptor area, is not assessed by this mechanism. Just 3 days back, we had the genotype-based decision-making algorithm, which is published in the journal Nature. So I'll be showing you that fresh data. And they have found some variants in both GLP-1 and the GIP receptors. If you have those polymorphisms, they can be blunting of response, and you can also predict the side effects of nausea and vomiting. What they say is, you have two types of alleles which are expressed. One is T and one is C. If the T allele is homozygous, that is TT, they are super responders. You can expect this patient to lose at least 10 to 15% of body weight from baseline. If you have the mixed phenotypes, heterogeneous, which is CT, you will have intermediate response. If it is homozygous CC, then the patients will not probably lose weight at all, or it will be less than 5% from baseline. What they've also found is that if you are expressing TT alleles, homozygous, the side effects, nausea and vomiting, runs parallel to your response rate. So the higher your response as far as weight loss is concerned, higher will be your nausea and vomiting. So you can predict that also. Now this part of GLP-1 receptor polymorphism is similar to tirzepatide. The difference is, in tirzepatide, there is one more receptor coming into play, which is GIP. So you can also have polymorphism in GIP. Now, why do patients being given a tirzepatide have lesser nausea and vomiting than those who are giving semaglutide? Because there is a GIP buffer. This allele is called the G allele. Now, if someone has a polymorphism and instead of G, this patient expresses the C allele, then the patient will have increase. This buffer will go and the nausea will go up. Remember, if you already have a TT, you already have an increased nausea, plus you're adding the CC. So the nausea will be increased 14-fold. So this is the allele-based decision making from the adverse effect. So if you have TT, if it is a GLP-1 receptor, if you have TT allele, you have the maximum response, weight loss, but you have also high rate of nausea and vomiting from the GIP-1 receptor activation. But if you now have a CC phenotype, which is the genotype of the GLP-1 receptors, then you'll have good response, but there'll be explosive nausea and vomiting. So this will be an ideal patient to be put on plain and simple semaglutide or GLP-1 and not on a dual agonist. So I'll give you a patient profile before I end. So here is a patient, 44 years of age, male. There is no diabetes, he's obese, BMI is 35. And you do remember, you can just do it by buccal swab. You just need a buccal swab and you have your genotyping done. So if this patient have a GLP-1 TT and GIP-CC, this patient will have explosive nausea and vomiting, but will be a super responder. Do not put this patient on tirzepatide. This patient should be on simple GLP-1 receptor agonist. So this is one way in which we can choose our agents. So I think this is still a paper which is mechanistic in nature, needs to be explored more. But with more molecules being available in the near future, I think we need more definitive ways of choosing molecules than just blindly putting them on one and seeing there's no response and putting them on the second one. So with that, I'll end my presentation. Thank you.
Thank you, sir, for this excellent talk. Do we have any questions from the audience? Since everybody is using these drugs nowadays. Sir, I have one question. Like, in clinical, how can we judge whether this patient will respond or not without this analysis?
That's what I'm proposing. It has not been tried in any clinical trial. We can ourselves pool our patients and see how it's happening. But I think definitely the hunger phenotype is something we have seen quite commonly, that it's not dying down even after giving GLP-1.
Yes, sir. After some days, it's just come back.
And we now tend to ship them over tirzepatide. It won't work.
Exactly.
So, we have to wait for cagrilintide, otherwise it won't work. But we are arbitrarily switching between them. So if a hungry phenotype individual doesn't respond to either tirzepatide or GLP-1, switching to the other won't make any difference.
And what about the nausea and vomiting? Is there any way to predict that in some patients? Because the new SEMA which we've been using, out of 100 patients, 2 to 3 patients have severe nausea, vomiting and loose motion. Is there any way or any paper available till now?
So what we have seen is this is, the commonly seen is called the first dose response. Yeah. You see it happens maximum with the first dose, with second it just goes off. For some, the vomiting goes off, the nausea stays back. One of the best way of doing is ask them to keep ginger in the mouth. That is also coming from the clinical trial. Ask them to keep ginger, review their diet, cut down on the fatty component part and increase the protein part, so that protein increases your satiety. Protein also increases your BMR so that you start losing weight and you feel hungry, you feel full for a longer period of time. So one fatty part has to be removed to keep ginger in your mouth. Most common drugs like domperidone and ondansetron actually doesn't work in this type of vomiting. It's very difficult to stop them by these agents. So drug-wise, it's very difficult, controlling this vomiting. Third is pace out. Sometimes instead of weekly titration, you can make it initially, you can make it twice weekly, and don't go to the next high dose for 2 months or 3 months and make the progression slow. We have ample data on that also, that you get your response.
One thing regarding the loose motions, like once the patient gets that, it's very hard to convince him to go for that drug, even in the lower dose. Sometimes people try like 0.25, they halve the dose and they convince them. So any experience in that?
Again, it can be explosive.
40
it
to
can
50
be 14,
times.
15, 18 times a day. Again, you need anti-secretory molecules like Z-dot and others in these patients along with lopamide. But the next shot patient will be extremely, again it may go up from the second shot, but convincing this patient to go for a second shot is extremely difficult.
Thank you, sir.
Thank you.
Our next speaker is Dr. So going further, Okay. Next, we have Dr. Jyotimay Pal, who will be speaking on will artificial intelligence may replace natural intelligence in future clinical care. Sir? Sir? Sir, Sir needs no introduction. Sir is a professor in the Medicine College of Professor Medicine in the College of Medicine at Sagore Datta Medical College. Is also the immediate past president of API, past dean of Indian College of Physicians, scientific chair and organizing secretary of APICON 2025, and sir has been the editor-in-chief and multiple other clothes to his. Over to you, sir.
Thank you. My session may be a break in obesity, in the obesity hall. Those who are Bengali, probably they have read the novel written by Tarashankar Bandyopadhyay in 1950 on Hasulibaki Rupakatha. This is a very beautiful novel written by him when he realized that urbanization is grasping the rural life, not only the life, the values, older tradition. And with the painful heart, he painted a beautiful story in his novel. We are at the juncture of a time when there is a conflict, tug of war between whether to accept the widespread use of artificial intelligence or stick to our traditional based, that is the clinical medicine. So, in my story, let us discuss from the historical background. 1811, the Ludwig movement, that was the first structured movement by the English worker, textile worker, against the industrialization. It was a revolution and against the social changes by the industrial worker in England. In 1986, Rajiv Gandhi brought the supercomputer India. In West Bengal, left parties start opposition with the apprehension that widespread use of computer, so many people will lose their job. 1997, a historical day, the IBM supercomputer Deep Blue defeated world champion Garry Kasparov in the chess match. And there is a historic day that showcased the power of artificial intelligence. So from that day, question has raised whether machine in future will dominate over the human power. 2023, then in New York, mom, there is a Japanese girl married a AI chatbot. So another question raised, whether in future artificial intelligence is going to replace the human touch, love, and passion. So this century, several questions has raised. Are we human beings are losing our power, our love, our sorrow, our passion, empathy, all to the machines? Answer is not very simple. Let us see. So traditional, now basically we are physician. Now our dilemma is whether to use the widespread use of artificial intelligence or clinical medicine. So traditional teaching of medicine, that is beautifully described by the McMaster University in their book, in their preface. Basically McMaster University is the birthplace of evidence-based medicine. And they in their preface, in their book, they are beautifully written that every profession has an inner core. And the medicine is basically an encounter between the two people, one patient, one is the doctor. An unique bond between the patient and doctor cannot be replaced by the most sophisticated technology, automatic application, scientific data or practice guideline. Who has written? It is the McMaster University editor has written, which is the birthplace of evidence-based medicine. So that is why the traditional steps in managing patient, first we make a rapport with the patient, we take the detailed history, we do the proper clinical examination. On the basis of history and examination, we do the analysis of the data, then we plan for the investigation, then with the investigation report and the history examination, we plan for their treatment. That is why the MacLears, that is considered Gita of all of us doctors, and we have read in our undergraduate days. It is written in their preface that history taking and clinical examination is the bedrock of the physician's art. That is why our traditional teaching, what we practice till today, we first make a rapport with the patient, and based on that rapport, we take the details history, do the examination, and based on this, we plan for the management. That is why bedside teaching still remains the pillar of medical teaching system. But now we are in the era of artificial intelligence. What is artificial intelligence? It is the development of the computer system that capable of performing tasks that typically require the human intelligence. That means it mimics the human intelligence. There is a basic three key principles of AI. One is the machine learning. That means we give the inputs, and based on the inputs, when we want something, some result, we ask them, and based on their data, they give their decisions or their predictions. Another is the deep learning. Deep learning is another subset that utilizes the multi-layer neural network to stimulate the decision-making power of the human brain. Another is the natural language processing. Natural language processing that enables machine to understand and respond to human language. So there is the three basic varieties of artificial intelligence. So that means artificial intelligence basically mimic the cognitive process of human brain. They can recognize the pattern, they can predict, they can analyze with speed and accuracy, and they can handle a vast data at a single point of time. But the difference from the cognitive domain of human and cognitive domain of artificial intelligence is that the artificial intelligence lacks the emotion, lacks the self-awareness, and lacks the creativity. How? We'll discuss. So there are several questions is coming at this juncture, whether AI is at all needed in our day-to-day clinical practice, whether AI is superior to the natural intelligence, whether AI can replace natural intelligence and instinct, whether AI-based judgment is superior to the clinical judgment, or we need both. So these are the basic questions. In AI in medicine, it used widespread. It is used in the primary healthcare level, at the super specialty level, in planning and management, in planning of drug formulation, in assesses treatment adherence, in research and publication. So in our every aspect of our clinical medicine nowadays, AI is going to be inevitable. In primary healthcare level, ECG, CT, X-ray analysis, detecting the basic pathogen when there is no expert. In the super specialty care, we see the widespread use in the cardiology, particularly the ECG, echo, CT, MRI, cath lab, EP lab. We see use in the gastroenterology, we see in the neurology, particularly the stroke thrombolysis, prevention of the stroke and assessment of the risk, brain imaging, MRI, MR angiography to assessment. Even if there is a lacking of the expert, with the use of the AI, we can get the result very quickly. So artificial intelligence basically is bringing a revolution in healthcare management, but there is a difference. So what is the difference between the artificial intelligence and human brain? Question is whether we do not need at all the human brain. We need it because there is some difference. What is the difference? AI can process the data with the speed much faster than the human brain. The memory capacity of AI is much more than the human brain. Learning ability, they can learn from the data, but human brain learn from the experience. But the emotional intelligence is lacking in AI, but which is present in human brain. Why? Because the artificial intelligence, we get the input, and based on the input, when we ask some question, based on the data, based on the memory, they give the reply. But human brain, the cognitive process, based on the not only learning, also the self-life experience, the data is stored. And this memory, human memory, with the association fiber, it is connected with the both temporal and parietal lobe and the frontal lobe. That means when we ask some question to the human brain, the judgment not only based on the memory that is stored, also it is governed by the both frontal and temporal lobe. That means the judgment, emotion, creativity, all are merged with the human memory, but which is lacking in artificial intelligence, because artificial intelligence is lacking the frontal and temporal lobe. This is the difference between the artificial intelligence and human brain. That means the response from the human brain may be guided by the personal experience, by the emotion, by the creativity, by the instinct. There is a natural intelligence, but artificial intelligence lacks such type of creativity. So if we summarize between the difference between artificial intelligence and clinical judgment, AI is based on the structured data and fixed program information. But clinical judgment not only based on the fixed judgment, also from experience from day-to-day life. AI lacks rapport with the patient, but the clinical judgment in the clinician can establish a rapport. AI lacks empathy, but the patient's care needs empathy. AI cannot consider patient's social and economic issue, but the clinical judgment, a clinician, true clinician, can address the social and economic issue of the patient. AI not fit for the individualistic medicine, but the good clinician can judge the patient and give the judgment based on of his individual requirement. AI lacks the ethics and moral judgment, but the clinician must have moral and ethical values. So many times I talk about the empathy, the artificial intelligence which is lacking. What is empathy? Just one small story I'll tell. Once Dr. Devi Shetty, everybody knows his name, that time he was in Calcutta. One day during operation, he got a phone call from a lady. Doctor, I am suffering from fever, please come and visit me. His assistant denied, told he is a cardiothoracic surgeon, what he will do going there. But the lady called him repeatedly. Then the Dr. Shetty agreed and went to her house. That lady was no other than Mother Teresa. And Mother Teresa that didn't told, I know doctor, by telephonically you can prescribe some medicine, but I need the touch of your hand. Because hands, doctor's hand, any hands that help are holier than the lips that pray. This is a famous quote of Mother Teresa, and that is actually the empathy. So conflict, what is conflict in one mind? Should we welcome artificial intelligence? If so, when and how much? Whether we should invite artificial intelligence in all sphere or in limited sectors. So there is a conflict. There is a very good story of the conflict. Those who are Bengali definitely have seen the movie of Mahanagar by Satyajit Ray, 1963 movie. That is basically a story of social conflict when the daughter-in-law accepted job because of the poor socio-economic structure, and his father-in-law, who is a traditional person and not accepted that daughter-in-law will go to the outside for a job. But finally his son lost the job and family become dependent on the earning of the daughter-in-law. So basically this is the story on a conflict. That means conflict is one of the core issue of human civilization. But question is, how will deal the conflict? That is your skill. Or how will adapt in the changing environment? That is also your skill. So conflict, how will deal the conflict? Now we have a conflict between the artificial intelligence versus the clinical judgment versus the traditional clinical teaching. So how will you address both of the issue? That is your skill, that is your power. Devashish Bhattacharya, because at the beginning I told the story when the supercomputer came in India, left party start movement with the apprehension that many people will lose the job. Devashish Bhattacharya, he is the author of the book of Exploding Marxist Bengal 1971 to 2020, 2011. He has written in his book that left parties, though opposed the introduction of supercomputer in India, finally they accepted, because though they opposed, but they failed to show any alternative, how the huge population India will get the job. So finally they also accepted the introduction of the computer in the Indian society. Kasparov, who lost with the IBM supercomputer that is made by the artificial intelligence, in 2016 in his book, very nice comment he has written, and that is the answer of today's debate. A weak human with a machine working in harmony is more effective than either a strong human or powerful machine working alone. That means you have to work together, then we can get the success, than working alone. So I'll finish with a story. This is a mythological story. Many of you know that Shiva and Parvati, they have a divine fruit. They told their two sons, Kartika and Ganesha. They told who will come faster to the mother will get the divine fruits. So Kartikeya has a Mayur, peacock. So with the peacock, he started moving the earth to reach to his mother. But Ganesha told, my mother is the earth. So what I will do, moving around the earth, I will move around my mother and come back. So Ganesh come back to his mother very quickly because he considers his mother is the earth. But Kartikeya start moving around the earth. So Ganesha got the divine fruits. So take home message. The message of this story is wisdom is greater than the speed. So it is important what therapy you are giving to the patient. It is important the way you are giving to the therapy to the patient. So a good physician, it treats a disease, but the great physician treat the patient who have the disease. So it is only possible with wisdom, empathy of a physician. So in conclusion, there is no conflict between artificial intelligence and natural intelligence. Creation cannot be greater than the creator. So artificial intelligence is not an alternative to the natural intelligence, but both should coexist, and human intelligence should intelligently use the artificial intelligence, and that is the answer of today's debate. Thank you.
Thank you, sir. And any questions for sir? Documents, fine. So we come to the end of this session. Thank you so much.
Thank you.
So thank you, chairpersons and speakers. We now move forward to our next session, which is on the science of obesity. To chair this session, may I request Dr. Rahul Bhattacharya sir to please come, Dr. Subhashish Roy Chaudhary sir and Dr. Sunil Gupta sir to please come on the stage and start the session by introducing our speakers.
So I feel we have a wonderful session now on this twin cretin, and thank you very much the organizers and the whole team of scientific committee for this honor and opportunity. And I'll just go through the scientific program here. This is how we. So we have, I feel, 3 speakers here, and day 1. Organizers should keep the copies here, no? Properly. Science of obesity, if I'm not wrong. Yeah. So we have this session on science of obesity, and we have 3 eminent speakers with us, Dr. Vikas Bhattacharya, Ipshita, and Dr. Ritesh. And this particular session is a sponsored session by Eli Lilly. And without wasting much of the time, because we are already delayed as per the schedule, may I invite Dr. Vikas Bhattacharya ji to take the first session, and it is on science of obesity and cross-connect with type 2 diabetes.
So, science of obesity and cross-connect to type 2 diabetes. Science of obesity is expanding actually, evolving day by day. And these are the disclaimers, disclosures, and this is the thing. So, neuronal and hormonal communication modulate food intake and energy expenditure, we know that. And there is hypothalamus, there is homeostatic eating, satiety, appetite, energy expenditure. There is mesolimbic hedonic eating, linking and wanting. And there is prefrontal cortex executive function, self-regulation and inhibitory control. With drugs, we can do about homeostatic, we can do also about, to great extent, hedonic eating. But then about prefrontal cortex executive function, we can develop with counseling, with cognitive behavioral therapy. And satiety hormones are there. We know that from intestine, these are nutrient-stimulated gut hormone, GLP-1, oxyntomodulin, CCK, PYY, and GIP. And we remember that these are short duration hormone, and we have made it very long duration, supraphysiological doses to make them anti-obesity or anti-diabetic medication. Leptin is secreted from the adipose tissue, but then in both the conditions, there is increased leptin, but they are resistant. They don't act like insulin resistant. In pancreas, two hormones, insulin and amylin. Insulin is a satiety hormone, contrary to the common understanding. And amylin also is being used now as an analog. And amylin can do one wonderful thing, that it can bring down leptin resistance. And there is single hunger hormone is ghrelin. But then interest has become very interesting now about ghrelin, that is the latest thing that come out in nature, that why snake can remain without for very long. And they have found that most of them don't have actually ghrelin gene, and those who have it, it is so mutated that it doesn't function. So again, there will be huge interest in ghrelin now, and companies or pharmaceutical companies will be interested to bring out a ghrelin antagonist probably. And adipocyte dysfunction is a key driver of related complications. This is the main thing. Adipocyte, that is doing all the bad things. And you can see that healthy individual display normal adipocyte. In obesity, adipocyte increases in size and number. There is hyperplasia and hypertrophy. Adipocyte dysfunction contributes to accumulation of lipid in ectopic and visceral depots, because there is overflow from the subcutaneous space, and all the bad places that get deposited, that epicardial, pericardial, hepatic, and all these, they are ectopic fat. And when there is retroperitoneal, omental, and mesenteric, they are visceral fat, and they are very, very inflammatory fat. And we know that enlarged and dysfunctional adipocyte lead to local and systemic inflammation and insulin resistance. And inflammation and insulin resistance. So what the link between inflammation and insulin resistance is that inflammation doesn't allow tyrosine kinase. That is very important for insulin signaling. Insulin bind to the insulin receptor, there is tyrosine kinase, but that doesn't happen in presence of inflammation, so there is insulin resistance. So there are different, definition is there. American Association says adiposity-based chronic disease, obesity, we know that. South Asian Federation is a very prolonged good one. SAFEs declare that obesity is a chronic, relapsing, multifaceted, multisystemic endocrine disease which needs timely and sustained attention at clinical as well as public health level. And Endocrine Society has got a shorter. Obesity is a chronic, relapsing, progressive disease defined by excessive adiposity that may impair health. So these are the definition, we know that. And many factors contribute to obesity. There are some written here, epigenetic, genetic, physiological, environmental. In fact, there are more than 200 causes are there. We know that. And simple thing is, following weight loss, what happens actually? Decreased energy expenditure leads to adaptive mechanism. And as a result, there is increase in hunger hormone and decrease in satiety hormone, and there is weight gain. So somehow, evolutionary, we don't want to lose weight. Somehow they cling to it because, energy was very scarce during millions of years of evolution, so the body doesn't want to lose it. And following weight reduction, most is regained over time. There are two studies are there. One is an Australian study, showed that during the follow-up period from the end of the weight loss program, at week 10 and week 62, participants regained approximately 5.5 kilo. And Anderson et al. Showed that percentage weight loss maintained and reduced weight at 5 years were significantly lower than the value at 3 years. So gradually you lose, control. And 79% of weight loss lost regained by the end of 5 years. So we regain. So only with lifestyle modification probably some people can do it. There are others, they can do, but most of the people it is not possible. We need other intervention. And this is the same thing written. Following weight loss, what happens? Hormonal changes, we talked about it, persist for 12 months. Hormonal changes persist for 12 months. Then leptin goes down. Leptin remaining high also doesn't mean anything because this is resistant. Ghrelin goes up. That is very, very important. GIP goes up. GIP actually, we talked about that before, it is to some extent is an obesogenic hormone also, but when act together, we make it, then it acts in a different way. So there is a lot of things we are understanding in obesity because both antagonists and agonists both act as weight reducing. So how they act, we are understanding gradually. And why? The body produces more hunger promoting hormone, we know that, we talked about it, and reduces satiety hormone. So that's how we gain it. The increased drive to eat and decreased energy expenditure resulting from weight reduction create a perfect physiological storm. This is a physiological storm actually. Revolt, body revolts. You are losing it. I don't want to lose it. And obesity related complication. There are so many, in 3 headings you can see the mental, mechanical and metabolic complication. All these are very, very important complications, including malignancy, whatnot, everything happens from. Because, is anyway, fat metabolism is much important from carbohydrate metabolism. It makes more disruption than glucose metabolism. And fat metabolism depresses glucose metabolism also. So we must think about fat metabolism. Now treatment guidelines. These are the European Association for Studies in Diabetes developing therapeutic goals based on severity and stages of disease while considering prevention of further weight gain and obesity-related complication. Edmonton scale is there. And ASE guidelines should be individualized based on medical history and presence of comorbidities and complications. So not only on BMI or weight, it is on other things that are associated with, treatment should be tailored. In type 2 diabetes, a higher magnitude of weight loss leads to better outcomes. So it is very, very important. Nowadays, type 2 diabetes is actually obesity driven. So weight loss has become a primary goal also. Not only glycemic goal is the primary goal, weight loss is the primary goal. And 5 to 10% yields metabolic improvement. We know just lowering 5%, you can have real control over glycemic control. 10 to 15% or more may have a disease modifying effect altogether and lead to remission. We know that. People with type 2 diabetes can especially benefit from early aggressive treatment. We need early aggressive treatment. A lot of things. Weight reduction at the beginning, from the very end. Not only in the beginning we should control hyperglycemia, but also we should think about the weight now. Damage caused by type 2 diabetes presents early compared to the ongoing lifelong benefits of the early aggressive treatment. So as early as possible, in type 2 diabetes, we must think about weight control. Recommendation on screening, diagnosis and assessment. Assess for the presence of obesity by determining the following parameters and categorizing based on their threshold values. BMI 18.5 to 24.9, that is normal weight. For us, it is a different, for Asian Indian population. From 23 onwards, we are overweight. From 27 onwards, we are obese. So this is for the, Caucasian population. Mostly for us, we have got a different guideline. And waist circumference is all right, 90 cm for men and 80 cm for women. All the cases we must know, along with BMI and weight, we must know about the waist circumference. And common recommendation, thoroughly assess overweight obesity patient with medical history, very important, physical examination and relevant lab tests. And all these are lab tests has to be done. We know that we have got a performer on that, protocol is that. And this is very, very important. We should always remember what is the benefit we get from weight reduction. Only 0 to 5%, hypertension control, hyperglycemia control. We have seen it again and again, but we should see it again and again. 5 to 10%, urinary stress, incontinence, PCOS, dyslipidemia, asthma, airway obstruction, MSLD. So a lot of benefit. 10 to 15%, MASH, OSA, GERD, and neo-osteoarthritis. It's a very, very common thing. And if you reduce weight, people get great relief. And 15% CB disease, CB mortality reduction, and huge benefit in heart failure for preserved ejection fraction. So what is this thing? Factors affecting islet function and connecting obesity in type 2 diabetes. Expanding white adipose tissue, there is beta cell dysfunction. That triglycerides go to the pancreas and cause a lot of beta cell dysfunction. And also there is inflammatory cytokines, and I talked about that it causes insulin resistance. So these two things, beta cell dysfunction and insulin resistance causes a lot of problem. Plus in the liver there is lipid accumulation, lipogenesis, MSLD, And so another problem is there. In skeletal muscle, lipid accumulation again, triglyceride accumulation, less glucose uptake, and less glucose oxidation also there. So as a whole, they lead to a big problem. And these are two cases. Patient X in 2020, how he was, 45 years old male, BMI 38, without type 2 diabetes. Patient with a history of obesity in the family and examination, 110 kilo body weight, blood pressure 135/85. Waist circumference, you can see 115. Others are hypertension, dyslipidemia. He has got almost everything. And that man, he didn't have type 2 diabetes at 2020. And 2025, 50 years old male, he has become with BMI now 40, diagnosed with type 2 diabetes, patient with a history of obesity in the family. On examination, he is now 120 kilo, blood pressure 140/88, waist circumference 120. Others, hypertension, dyslipidemia is there, and HbA1c has gone up to 8.5. So, if we would have done something in 2020, he would not have landed up there. So these are the scenarios. What you can do in 2020, we could have reduced body weight, blood glucose, risks of type 2 diabetes, and other complications also. In 2020, you can do this body weight reduction, blood glucose, other complication, and treatment costs. So treatment cost has gone high. So thing is that do it fast, do it aggressively. So addressing weight as early as possible is the thing. We have understood it already, earliest possible. And this is the thing only, circadian clock disruption in obesity type 2 diabetes. There is a central clock in the suprachiasmatic nucleus, and there are other clocks in the periphery. If there is desynchronization, there is all problem. It leads to gluconeogenesis, insulin sensitivity, lipid homeostasis, all problems happen. There is problem with lipid secretion, adiponectin secretion, insulin sensitivity goes down. So problem is that we should have a synchronization between central clock and peripheral clock by doing the thing in the right time. So that is very, very important. And daytime, nighttime, very late eating, seeing cinemas late, and, more time nocturnal time you spend, more you become prone to obesity. That is the thing they are saying. So that is very, very important, how we lead our life. And this is the key takeaway message there very clearly I have told you. And thing is that we must take care of obesity as early as possible. Thank you so much.
Thank you, Dr. Vikas. And Dr. Vikas is a big man when it comes to obesity. He's a very core group member and an office bearer of our RO. And he recently, let's give a big hand for his selection to be there, is there in the national body of RO of 2026 to 28. So congratulations to you, sir. So we have now the next session. We have a discussion and we have question answer at the end. So we have now Dr. Ipshita Mishra. May I invite her from Bhubaneswar? And she's going to speak on Surpass 2, and then we'll have surmounting, and then we'll have discussion. So Dr. Vikas will sit here on the dais, please. And then, yeah. Okay, so do we have any question for Dr. Vikas Bhattacharya, because he has to catch his flight? So Dr. Vikas, Dr. Vikas, can you just come on the dais? Yeah. We'll have one or two questions for him, and then because he wants to leave then. So Dr. Vikas, as a clinician, now you have told about everything, that obesity is important, diabetes, obesity has a very close link. And everyone wants to, if you control obesity, possibly you'll be able to not only have a primary prevention remission for the diabetes, but also there are a lot of scope of, going for preventing complications. So how will you bring the awareness amongst people about obesity? What is your quote on the final word on that? You can be on the dais. Yeah, madam, can you just, yeah, please, thank you.
That is the biggest thing actually. And two levels are there among our caregivers. It should be that. Most important, we are here to tell all that. We must know that, it is a huge problem. It is not still recognized as a huge problem. In a patient with obesity and diabetes, most of the time we are thinking about how to control hyperglycemia. At the same time, I think it has become a primary goal now. Co-primary goal, or maybe this is the first goal, then the hyperglycemia is the second goal. So this is very, very important. We must understand that we must take care of obesity. Obesity doesn't mean only BMI and body weight. It is waist circumference and many more things and measures are there. And that is very, very important. And second is, of course, public awareness. We are part of it as a whole. All stakeholders are there, social, national, all stakeholders are there. And now people are gradually understanding that it's a good thing happening. And a lot of awareness among us. But we must develop more and more awareness. And that is very, very important.
I feel that's a very good message from Dr. Vikas, that now people are really getting aware of obesity, and the social awareness has certainly increased after the launch of these molecules, and that's a big thing for us, and maybe in future will be acceptability will further increase. That's what is. Thank you very much, sir.
Absolutely,
thank you. Thank you. Ishpita, it is your turn for surpass, and then if you can be a little brief because we are delayed by almost 20 minutes, so if you can just save 2 or 3 minutes at the end. Yeah. So this is, she's from Bhubaneswar. She has done her MBBS MD from there and DM endocrinology from Cuttack. And she's also the professional members of multiple organizations, 34 publications. Over to you, Shpita.
Thank you so much, sir. First of all, I thank Dr. Supratik and Dr. Anshin for giving me this opportunity. And we know that this is a Lilly-sponsored session with certain housekeeping rules. Well, we have been understanding these group of molecules, these twin cretins, more so since last 10 and 11 months. But it is not that the identification of these molecules, it's not happening right now. The identification of these molecules dates back to long back in 1960s, 70s, where the concept of incretins evolved after the clamp studies. So what they did in the clamp studies, that is the euglycemic clamp studies, you infuse IV glucose and you give an oral glucose. So there was marked difference in the release of insulin from the pancreatic beta cells. So this led to the idea that there is something when we eat probably which stimulates the pancreas to release more of insulin, and this is how the evolution of incretins came up. So incretins belongs to, there are two molecules, we have heard about that, the GIP, the gastric inhibitory polypeptide, and the GLP. Now both of these, they have been identified again since last 1960s, 70s, secreted from the gut, the small intestine. The GLP is from the ileum part and the GIP is from the K cells in the duodenum. So initial interest was the release of insulin from the pancreas, but with evolution, when we have understood these molecules, GIP and GLP, so GLP came up much earlier, late 2000s it came up, because we were interested in the glycemic management only. So apart from that, if you compare GLP and GIP, the evolution of GIP was little bit late, because at the level of the pancreas, GIP was found to have more of glucagon release. So the GLP agonists came up much earlier in comparison to the twin cretins. Now interestingly, we knew that apart from the effect on the pancreas, what they do at the CNS is they have controlled the mechanism of food intake by balancing between your satiety and the interest in the food. So that is something which was there. At the level of the stomach, there is definitely delayed gastric emptying. Now this plays a very important role in the management of weight related affairs, which was found out from, of course, from the bariatric surgery modalities. GIP, apart from this, the interesting part was at the level of adipose tissues, how it modulates the adipose tissue mechanisms. So at the adipose tissue mechanisms, not only it causes an alteration in the insulin sensitivity, but if you look down, it has got a capacity on the lipid buffering mechanisms, it has got a capacity on the fatty acid oxidation at the level of adipocytes, and a pro-inflammatory kind of an action which is there at the level of adipocytes that is suppressed by this drug. So this led to an interest, and this differential action at the level of adipocytes, what has been extrapolated, and we have understood that. So whenever we eat, we have the most strong stimulus that was to our understanding to release insulin is the glucose, which glows and sits at the GLUT2 receptors present at the pancreatic beta cells. But apart from that, these incretins, and most importantly, GIP was identified as a relatively more strong stimulus to the tune of 45% that causes release of insulin from the pancreatic beta cells in comparison to the glucose and the GLP-1. So when we eat, and especially if you eat a meal which contains more of fat, so it along with the insulin release which is happening, it causes more of uptake of the glucose into the adipocytes and more of storage of kind of fat happens at the level of the adipocytes. But when the glucose is low, it causes release in the glucagon. So it was not that simultaneously it causes release of glucagon and insulin at the same time. Probably when the glucose is low in circulation, there is increase in glucagon, and this was understood. So this action, these mechanisms of actions led to the evolution of the twin creatines. Most interestingly, the extrapolating the way it modulates the lipid mechanism at the level of adipocytes. So tirzepatide, we have understood tirzepatide more so since last 1 year. So we know that this is more similar to the NAVE GIP sequence. More homology is there with the GIP in comparison to the GLP, and the long half-life of this drug enables it with a once weekly dose therapeutic regimen. So if you look into the dose adjustments, well, we do not have large data, but any GFR less than 20 and Child-Pugh stage B and C, of course, we do not use it as of yet till data is not available. So we have understood these mechanisms, how they act, apart from the pancreas, apart from the central nervous system, apart from the gastric emptying. Now we are having synergy NASH because these group of drugs are very good in taking care of MASLD or MASH whatsoever. And of course, insulin sensitivity is improved. So now it's the era of evidence-based medicine, data based on RCTs, data based on SRMS. Tirzepatide has undergone extensive trials, one in patients with diabetes, one in patients with obesity without diabetes. So surplus group of trials which were conducted in the diabetic patients, quite a number, around 6,000 to 7,000. Multiple trials. 2 is what we are going to talk of, because here it has been compared head-on with another long-acting GLP-1 analog weekly once, that is semaglutide. So if you look into the SURPASS-2 data, the population who were included had a mean BMI of around 34, long duration diabetic 8 to 9 years, and who had not a very good attainable HbA1cs. The mean was around 8.3. Now this is interesting because once the onset of diabetes is for a longer duration, per se, the incretin related mechanisms which operate in the human body, that comes down. So here tirzepatide has been compared with 1 milligram of SEMA, because at that point 1 milligram of SEMA was the one which was there and which was in trials. So the primary endpoint was after the end of 40 weeks to look into the rate of reduction of HbA1c. So various doses of tirzepatide marketed by the name of Mounjaro by Eli Lilly was compared with 1 milligram of SEMA. And if you look into the primary endpoint, the rate of reduction of HbA1c at all the doses of tirzepatide 5, 10 and 15 was much superior in comparison to 1 milligram of SEMA at the end of 40 weeks. Apart from that, the consistency of maintenance of HbA1c at the end of 40 weeks was also superior even at the lowest doses of tirzepatide versus 1 milligram of semaglutide. In comparison to that, this is the comparative data. The rate of reduction of HbA1c to the tune of 6.5, 5.7 was most maximum, rather I would like to say, in all the doses of tirzepatide versus 1 milligram of SEMA. So the key secondary endpoint was to look into the rate of reduction of weight in terms of percentage I will speak of. So if you look 5, 10 and 15, so the minimum weight loss in terms of percentage was around 8 at 5 milligram of tirza, which was much higher in comparison to 1 milligram of SEMA. Now here we need to consider that the comparison is done with 1 milligram of SEMA. We do not have a comparative data in diabetic patients with 2.4. It is there in the individuals without diabetes. Some amount is there. So if you look into this, the rate of reduction of weight was again much superior at all the doses, and we know that if for a diabetic patients, if we attain a reduction of weight in terms of percentage, even if it is 5%, then we can take care of lot of complications, especially the metabolic related problems, and also, of course, if they are on other multiple therapies, the degree of reduction in those therapies, we do attain that, and we are seeing that also after using Mounjaro in our clinical practice. So this is that most of the patients and maximum of the results is of course present at 15 milligram of tirzepatide. So around 2/3 of the patients at the highest dose of tirzepatide attained all the 3 goals. Another important one was attainment of no significance or severe hypoglycemia. So adverse events, we knew that the GI adverse events, and still in routine clinical practice, mostly these are the gut-related adverse events, happens at the point of initiation or at the point of escalation of the dose. But now, after using the drug for around 10, 11 months, we do notice certain other adverse events. We have seen urticaria in our clinical practice. We have seen if somebody has got a pre-existence kind of a chronic hyponatremia CR, there is a risk of worsening of hyponatremia. And I found an accelerated hypertension in one patient. Causality I could not attribute to that. The patient was per se normotensive before taking the drug therapy. So these are that. And in diabetic patients, whenever we are using twitcretin based therapies, a risk of hypoglycemia do exist, especially if they are on SUs or if they are on insulin preparations, but Supras 2 didn't compare those group of drugs. So overall comparative occurrence of hypoglycemia, SEMA versus all doses of tirzepatide, they are almost similar. Severe hypoglycemia was less. So just to sum up, definitely now we have a molecule, if you talk of diabetic patients who takes care of a very good glycemic control and has got data in terms of reduction of the fat mass, quite superior HbA1c reduction, 2 to 2.5%, which of course, though the patients who were there in these group, we do not know what was the percentage of micro and the macrovascular complications at the time of enrollment of the study. And later on, if there is a reduction in HbA1c, though that degree of benefit in terms of complications are not great, but still, if 2.5% HbA1c reduction is there, then definitely you can have at least suppression if at all your patient has got some amount of complications set into that part. Weight loss is there and safety profile is very good, because whenever we give a drug therapy, safety is something which is very important, and we have very strong data related to that part. Thank you so much, sir.
Ripshita, please come and join us here. We will have the questions at the end of the next talk. May I now request Dr. Ritesh Kumar Agarwala, who will enlighten us about the SURMOUNT trial.
Good afternoon all. At the outset, I again thank Supratik sir and the organizing team for giving me the opportunity here and setting a stage of such a great scientific agenda which gives knowledge about the management of metabolic syndrome. From today morning also we are discussing more on the GLP, GIP, amylin and all these things. So more focusing on the metabolic parameter, and you too agree with me that in the management of diabetes now we are not looking towards the glucocentric approach, we are looking toward the metabolic centric approach, where blood glucose itself is not a disease. Because of the metabolic dysregulation, we are putting ourselves towards the inflammatory stage where it leads to type 2 diabetes, dyslipidemia, hypertension and cardiovascular disease. So from the beginning, if we are targeting this metabolic syndrome by decreasing the adipocyte or decreasing the inflammatory marker or decreasing the weight, definitely we will give a beneficial outcome to our patient. Weight loss medications are studied since last 50 years, but because of the effect and side effect, they are withdrawn from the market. And for the last 5 years, we have two of the molecules, GLP, GIP, and in future we are coming with the triple agonist, amylin agonist, and others in the management of obesity, which not only take care of obesity, but also prevent or progression of diabetes is also prevented in this group of molecule. So in that regards, as I am also a sponsored program of Eli Lilly, where the tirzepatide has proven its efficacy in all terms of preventing overweight, where SURMOUNT trial or trial 1 to trial 5, it gives all the evidences for your patient, how the weight loss helps, how the weight loss is maintained and without or minimal side effects for the patient. So this is the disclaimer, and already some of the part of the GLP-1 and GIP we are listening from the morning, and my previous speaker also highlighted about the role of the GLP-1 and GIP in physiological and the PKPD of the tirzepatide, where as rightly said, the GLP-1 which mostly act at the brain, pancreas and muscle. And where the GIP scores over GLP is the adipose tissue. So GIP mostly in the adipose tissue, it improves the insulin sensitivity and alter the nutrient metabolism. So by combining the GLP and GIP, it gives a synergistic action in terms of weight reduction and more beneficial effect by increasing glucagon and acting at the CNS, lesser side effect compared to the GLP-1 analog alone. And the tirzepatide, which is a more homology, 90% homology to the existing GLP-1 and GIP with a half-life of 5 days, so you can use weekly therapy and it has a buffer period of 3 days. And potential action, if you see the GIP, GLP-1 based on the clinical and preclinical research, the GLP-1 mostly acts at the CNS, improves the satiety and decrease the food intake. At the pancreas, increase the insulin but decrease the glucagon, where the GIP causes increased glucagon. Adipose tissue level improves the insulin sensitivity, improves the storage capacity and decrease the pro-inflammatory immune cell. Systemic decrease hyperglycemia, and one more important thing of the GIP, what you are not getting with the GLP-1 analog alone, is the action at the skeletal muscle and the bone. In the bone, GIP helps to improve the mineralization, so the osteoporosis risk in the tirzepatide group is lesser compared to those who are using GLP-1. So it promotes the bone formation compared to the bone resorption. So the GIP has an extra beneficial effect over GLP and acts as a synergistic action. And here you see the tirzepatide exerts its action via both GIP and GLP receptor in human. And when you see the antagonistic action, when the GLP-1 receptor analog alone, GLP-1, GIP and GLP plus GIP, the insulin secretion potential when the both GLP-1 and GIP antagonism produce similar effect compared to the monotherapy alone. And targeting this metabolic matrix, tirzepatide in terms of acting at the pancreas, it controls the blood glucose level. It causes weight reduction by targeting at the CNS and slowing the GI motility. It improves the dyslipidemia part by acting at the lipid partitioning and adipose function, and it improves the cardiovascular effect by improving the blood pressure, pulse rate and cardiovascular safety in patients with type 2 diabetes. So coming to the glycemic control, if I will say, if you see the 4 part of this GLP-1 GIP in glycemic control, weight reduction, lipid metabolism and cardiovascular. Coming to the glycemic control, what are the data available with us? We have discussed about the SURPASS trial where the molecule 5 mg, 10 mg, 15 mg is compared with the semaglutide 1 mg, and the HbA1c reduction is dose dependent with up to 2 to 2.5% reduction over a period of 40 weeks of trial. It also seen the first phase insulin secretion and second phase insulin secretion is also more in the combination therapy of GLP and GIP compared to placebo and semaglutide 1 mg. And the tirzepatide, if you see the glucose infusion rate and whole body insulin sensitivity over a period of 6 months of the trial, it is superior in the GLP-1 and GIP group of molecule compared to the GLP-1 and the placebo. So over a period of time with the glucose infusion rate, there is a significant improvement in the insulin secretion and insulin sensitivity in the hyperinsulinemic euglycemic clamp technique. It also shows the change in insulin and glucagon area under the curve compared to the placebo over a period of 6 months of the therapy. The total insulin secretion and the glucagon secretion with the combination therapy is better compared to the GLP-1. And the change in target plasma glucose to target post-glucose nadir 45 milligram per deciliter compared to the placebo, it is better in the GLP-1 and GIP group. So in the glycemic parameter, if you see, tirzepatide improves beta cell function and sensitivity, demonstrate greater reduction in the glucagon area under the curve, and intact glucagon response because of the GIP has lesser risk of hypoglycemia compared to other molecule. Coming to the weight reduction potential, as we all know, the weight reduction potential is mostly marked by 2 parameters, one acting at the CNS and one acting at the GI tract. So if you see the weight reduction potential, we have SURMOUNT trial 1 for the non-diabetic population, SURMOUNT 2 for the type 2 diabetes population, and SURMOUNT 5 were comparing with the semaglutide. So tirzepatide 5, 10 and 15 milligram, there is a significant reduction in the body weight over a period of 72 weeks of the trial of around 20 to 22% of the body weight reduction from the baseline. And if you see the body composition compared to the placebo in the SURMOUNT 1 trial, the total fat mass reduction is of around 33%. It is 100% sure that the 10 to 20% of the lean body mass is also reduced with the use of this molecule. But even if the muscle loss is there, the muscle efficiency has improved, and it has been seen then the type 2 muscle fiber is better in the tirzepatide arm compared to the placebo. So lean mass 10 to 20% reduced, but the muscle efficiency has improved with more than 70% fat mass loss. But yes, you have to advise the patient for the regular physical activity and the protein diet. And if you compare overall appetite compared to placebo in the participant with obesity, with the hunger score, in the prospective consumption score, overall appetite score, all are improved or reduced with the tirzepatide group of arm compared to the placebo. So they conclude tirzepatide lowered appetite measured by an increase in overall VAS score, tirzepatide decreased hunger and prospective food consumption and increased fullness, but did not change the satiety which is seen with the GLP-1 analog. It also decreased the craving from the baseline compared to placebo, and in that way it will reduce the body weight, and it has been seen in the trial that it specially decreased craving for the sweets, carbohydrates, starch and fast food fat, but not for the high fat and fruits and vegetables. So this is the typical food craving parameter they have studied in the SURMOUNT trial. It also shows greater body weight reduction compared to semaglutide in driven fat mass loss in participants with type 2 diabetes. And we all know there is a direct comparison with the semaglutide in SURMOUNT 5. Fat mass loss compared to the semaglutide is statistically very much significant. Fat-free mass loss and change from the baseline in body weight over time is superior in this group what you need for your patient. So in terms of weight reduction, if you see greater body weight reduction compared to semaglutide, reduced food intake, overall appetite and food craving, and with type 2 diabetes, greater body weight reduction with more than 2% HbA1c reduction has been noticed. Coming to the lipid parameter change, the pulse rate and blood pressure change with tirzepatide and semaglutide in participant with type 2 diabetes in your SURMOUNT 2 trial, the pulse rate change is not much significant, but the blood pressure reduction with systolic and diastolic blood pressure reduction has been marked with 6 to 8 millimeter of mercury in systolic and 2 to 3 millimeter of mercury in the diastolic blood pressure reduction. And tirzepatide did not increase risk of MACE in participant with type 2 diabetes with a hazard ratio of 0.80. Recently, SURPASS-CVOT trial is there where they have compared this molecule with the dulaglutide, which shows non-inferiority of the molecule in the cardiovascular 3-point MACE outcome. But recently, the SURPASS-CVOT trial shows superiority in recent outcome with compared to the dulaglutide. Patient with obesity without type 2 diabetes, they have shown improvement in the metabolic parameter both in dyslipidemia part and the blood pressure outcome. So the key takeaway, if I will summarizing the role of this molecule in the metabolic matrix, it not only improves the glycemic goal, not only improves the body weight parameter with lesser GI side effect compared to the competitor, it has its action at the CNS, it has its action at the liver, pancreas, cardiovascular reduction, GI tract, and the major region where it will act is the bone and adipose tissue, which is the main mechanism or synergistic action of the GIP along with the GLP analog in the management of metabolic syndrome. Thank you for your kind and patient hearing.
Thank you, Dr. Ritesh. Please come and join us. Now I invite questions from the audience if you have any. Please stand up and ask your question.
doctors for nice presentations. I've got a small
Can we have that mic on, please? Or can you increase the volume? Yeah. Yes. Yes, sir, you go ahead. Yeah.
audible.
You can be a little closer to the mic.
Yeah.
Yes.
Do you really recommend, say, eye checkup and say liver disease checkup before starting this molecule? Because there is a serious concern about this. Because in the practice, in the clinical practice, the periphery is sometimes very difficult for those patients to go again for all those checkups, and sometimes I feel after starting these molecules, the other checkups for the status, actual status of the patient and the, say, adverse reaction profile becomes very difficult. So that's one of the most limiting factors.
So the message is very clear from our esteemed delegates. Yes. Whether if a patient comes to you, whether we should go for sonography to see the gallstone, whether we should go for retina evaluation if they have pre-existing retinopathy and if it is, whether this needs treatment, and how should we go ahead. Even if they have, say, PDR, will it be any contraindication, relative contraindication? Will you treat the retinopathy first and then start the molecule? How will you keep a follow-up? There are no clear guidelines. So what's your take on that?
So in terms of retina examination, especially if we are treating this molecule for type 2 diabetes patient with obesity, you have to check the retina examination, though guidelines is not there. Whatever the eye problem we are seeing with the GLP-1 group of analog, there is no direct causal relation has been established till now. But it has been seen that acute decrease in the blood sugar level. So those group of patients who have uncontrolled diabetes with moderate to severe PDR, it is better to avoid this group of medication till your ophthalmological problem is stabilized. In non-diabetic patient, there is no problem. Now a dedicated trial is going on with the semaglutide, is the focus CD trial, to find out the causal relationship between the ophthalmological problem and the GLP-1 analog. Coming to the gallstone part, there is a risk of development of the cholelithiasis with the use of this GLP-1 and GIP. So you should do a ultrasound, but cholelithiasis itself may not be a contraindication for the use of this molecule. So clear-cut guidelines will not say anything. Your clinical judgment at that time will guide the patient better.
Ipsita, whether you have some additional point. If suppose someone has a family history of pancreatitis, someone had 10 years back a history of pancreatic, suspected pancreatitis, will you advocate this therapy?
So family history of pancreatitis per se is not a contraindication to start this group of drug therapies in a patient. But if the patient had a history of pancreatitis 10 years back, so it was not proven, acute pancreatitis. But then if you have done a USG later on and you have seen that the morphology is good, there is no evidence of any pseudocyst, if the pancreatic functions are good, then you can initiate the drug therapy, but then with caution. Per se, a 10-year history of pancreatitis, even in those group of patients who had acute pancreatitis, recover 10 to 12 weeks later on, we are giving them second generation SUs. It's not that we are putting them on insulin therapy for management of the glycemic part. And absolute contraindications, men, multiple endocrine neoplasias, MTCs, these are the absolute contraindications.
So if suppose someone comes to you with triglyceride of 1200, we know that, and an alcoholic, doesn't want to leave alcohol at all, obesity with BMI of 32, what will you do?
So at that point, sir, first I would like to bring down his triglycerides, because any TG more than 500 has got a risk of causing pancreatitis. So I would put him on therapies. We can put him now, we have icosapentaenol which is approved, and triglycerides too high, they are doing very good on that, apart from fibrate. Lifestyle little bit, then once it is stabilized, maybe less than 500, then I can initiate on this GLP group of GIP group of therapies, but again with caution. I personally feel that, as Dr. Ritesh has pointed, many guidelines we do not have, so it's our clinical judgment whenever we are using these group of therapies for any patient.
So AI may not be of much help here. We have to have a common sense using
at this point in time.
Yeah. So now let me go back to Ritesh, and of course my co-chair will also be agreeing on this. There are many type 2 diabetes patients who are obese, requiring 100, 150, 200 units of insulin. Still HbA1c is 10, 11, 12, not getting control. You suddenly you put them on GLP-1 analog. Their C-peptide is of course normal. And you put them on GLP-1 analog. They're already on metformin and sulfurias and what nonsense. All oral drugs already on. Along with that, the high dose of insulin not getting controlled. The moment you put them on GLP-1 analog or the twin cretins like tirzepatide, we have used this drug in multiple such patients, and we have found the insulin requirement comes down almost by 30 to 40%, though data says 20%. But we have seen even 50% reduction of the insulin requirement, and even HbA1c has got control now, which was 11, 12, now it's come to 7.5. So multiple such experiences. What's your take on that, both of you?
Rightly said, sir. As we have seen that there may be pleiotropic effect of the molecule, and because of the decrease in food craving with decrease in glucotoxicity might be with the start of the molecule, there is improvement in the insulin sensitivity and there is decrease in dose of the sulfonylurea and insulin. Rightly said, sir. Again, the percentage of insulin reduction is varies from person to person. So definitely it is 20% to 50% what you have said is correct, sir.
What's your take on practicability of, suppose someone here sitting, many people, they are getting a patient, like what I explained to you. What precaution they are supposed to take before starting the therapy?
So if
apart from retina and gallbladder.
If for diabetic patients on polypharmacies, as I told, SUs and insulin, then you have to tell them that if at all they are not on any CGMS device, which most of our patients do not have, so you develop the symptoms of hypoglycemia, come down, we'll start decreasing the dose. So that should be something which has to be told. And then second thing is that most of our Indian patients have got component of autonomic complications, including diabetic gastropathy. So exacerbation of the diabetic gastropathy related complications must be told. So related to food habits, portion control, those things must be educated prior initiating these therapies in the long-standing diabetic patients. Another thing, when we initiate these group of drug therapies to a relatively elderly diabetic who had been a long duration diabetic, the expected outcomes in terms of weight loss should not, we should be telling them that we may not get too high degree of weight reduction or fat reduction per se. So that is something which has to be told. And these group of drug therapies, as we know, the ceiling effect starts happening maybe at around 12 to 18 months or 24 months. So beyond that point of time, so in terms of the reduction in the weight or the fat content, that overzealous expectations of the patients is something which needs to be counseled little bit.
Okay, now the rapid fire, 10 seconds. Pregnancy, tirzepatide.
Not recommended.
Preconception, tirzepatide precautions.
Preconception tirzepatide recommendations should be told. That has to be told. So ideally not to be avoided.
No, someone coming to you for fertility clinic, PCO, lot of weight, BMI of 35, wants to reduce weight,
sir,
already on tirzepatide, planning pregnancy, what precautions?
We can give them barrier protections at that point and little bit delay, at least for 6 months till we get the weight related
When should we withdraw the therapy? Madam, yeah, when should we withdraw the therapy? So tirzepatide should be withdrawn at least one month prior to the procedure. Any of the fertility process. Madam, please.
Achha, I have one question.
I feel this is the last question because we are already...
Yes.
Yeah.
Achha, sir, regarding to autistic patients, autism spectrum disorder, taking medicines like aripiprazole, aripempti, but weight is greater than 100 kg, young age 23 years. Can we give this type of medicine? Aripempti for 10 years she is taking, but she is very fatty, not listening to, not eating less or doing exercise.
Yes, sir. These group of drug therapies had got causality of suicidal attempts in those patients who had got a spectrum of neurocognitive part. But per se in autism patients, how they would behave, there is no data. I will not say that we cannot give if the weight is, BMIs are like more than 40. We can initiate, but with caution, and here the caregivers, they need to be a bit cautious.
Depression risk is always there with the molecule. So don't give this molecule to those group of patients who are having antidepressant medication.
So here the patient is autistic.
So my question is about the weight loss comparison between SEMA and tirzepatide. you have shown data from SURPASS 2 where SEMA was used at 1 milligram dose only. So we don't have data. So we have data from STEP trials that the weight loss difference between 1 milligram and 2.4 is almost double.
Double, right, sir.
So what is your practical experience, because both of you have been using these two molecules for quite some time now. So what is that? I believe this gap will not be that dramatic.
Yet 2.4 milligram versus 15, till I have used her until 10 milligram. Very few patients on 15 milligram are there. Definitely it is, results are relatively more superior in the TIRZA versus 2.4 milligram SEMA. That's there.
I feel we need to wind the session. Thank you very much for the organizers. Thank you.
Thank you.
So we will now move on to our next session, Obesity in Motion, for which we would like to call upon stage Ms. Dr. Kirtish Suta and Dr. Seema Sahi. And with them, the moderator, Dr. MP Borua.
Moving on to the next session, Obesity in Motion. For the session, the first topic, Unraveling Obesity, the what, why and how. I would request Dr. Rutul Goklani to kindly come on the dais and give his presentation. Dr. Rutul is a consultant diabetologist at Ahmedabad, chief diabetologist and managing director.
Thank you, ma'am, for kind introduction, and thank you, Dr. Supratik, Dr. Gaurav, and Dr. Anchin Kalia for inviting me to this wonderful conference of EMOCON. And I'm really privileged to be here every year. Almost for last 3 years I'm coming. And today's my topic is Unraveling Obesity, the what, why, and how. And today's my talk is sponsored by Eli Lilly, and I have no other disclosures. So obesity on a steady rise, and we all know if you compare it to 2005, so before 20 years, according to NFHS data, it was done in 2005-2006, it was in men around 9%, and in women it was around 12%. So recent NFHS data is usually done between 5 to 10 years. This survey is done, National Family Health Survey, and after 15 years it has jumped to almost doubled or 2.5 times higher in obesity rate. So in this NFHS data of 2019 to 2021, it has increased to almost double. So in men it is 22.9%, and in women it showed 25% of obesity. So state-wise, if you see obesity prevalence in India, abdominal obesity has been rise globally since 1990. So which calls for attention to be paid in this emerging characteristic to assess the potential risk of associated metabolic diseases.
And 23% of women and 22.1% of men are overweight as per BMI criteria. But what about mono, which is there according to ICMR study? 40% of women and 12% of men are abdominally obese in country. So prevalence of abdominal obesity with waist circumference is with more than 80 centimeters, and in women of age between 15 to 49 years in Indian states. So prevalence of overweight in children under 5 increase from 1.9% in NFHS 3 to 4%. So even in children, obesity in children has also increased by 200%. So obesity is a chronic multifactorial disease, and we all know, we just understand obesity as overeating disorder and sedentary lifestyle. But it is more than that. It has epigenetic cause, genetic cause, environmental factors, physiological factors, and socio-cultural and behavioral. This is what I was talking about, that overeating pattern or sedentary lifestyle. But obesity is more than that. So excess adiposity is the key component of obesity disease. And according to CEPHIS and Endocrine Society of India, the main cause here which is shown for obesity is adiposity. And multiple organizations have given the different definitions, including American Association of Clinical Endocrinology and ESI CEPHIS. They clearly defines that excessive adiposity is the common cause of obesity, and where Obesity Medicine Association, where a chronic, progressive, relapsing and treatable multifactorial neurobehavioral disease, wherein an increase in body fat promotes adipose tissue dysfunction. So this is the key component. Adiposity is there, but adiposity dysfunction is the key cause of obesity. Hormonal signals affect body weight via food intake and energy expenditure, where 4 important factors including adipose tissue, pancreas, intestine and behavioral therapy, where behavioral problems, where a reduction in leptin, amylin, insulin, GLP-1, GIP, cholecystokinin, oxyntomodulin and peptide YY, this all reduces, but the hunger hormone in stomach, which is ghrelin, which is increased, and in this ghrelin increase the appetite. So ultimately these hormonal signals, they affect body weight via food intake and energy expenditure. So whatever we have to work upon mainly is to reduce the ghrelin, and it is more important than any other hormone in our treatment armamentarium. So neuronal and hormonal communication modulates the food intake and energy expenditure, where you can see in brain importantly 3 parts: mesolimbic system, where the hedonic eating pattern is controlled; hypothalamus, where homeostatic eating is controlled; and prefrontal cortex, where executive function is mainly maintained. So in mesolimbic system, there is liking and wanting. This is hedonic pattern of eating, where you just want to eat. You are not hungry, but it is hedonic pattern of eating where you just want to eat because you like it. Whereas in hypothalamus, it is mainly homeostatic. So whenever your blood sugar is low and you want to eat, this is the homeostatic pattern of eating, and it is regulated by hypothalamus. Whereas in prefrontal cortex, it is self-regulation and inhibitory control. through different various hormones. So fat accumulation and associated adipocyte dysfunction. So important thing here is adipocyte dysfunction that you need to remember from these slides. I know these slides are maybe 1 or 1.5 years old, but these are still relevant. So adipocyte dysfunction ultimately leads to chronic inflammation and accumulation of cytokines, and ultimately it leads to insulin resistance at various part, and it causes visceral part of adiposity, and this visceral obesity or adipocyte dysfunction is the main cause in obesity. So sample of pathways from adipocyte growth and dysfunction leading to obesity related complication, where different pathophysiological mechanisms like we study in diabetes, AMOCE octet. Here also adipocyte growth dysfunction in obesity, which has various pathophysiological mechanism, which includes insulin resistance, inflammation and dyslipidemia, increased blood volume and high angiotensinogen, increased visibility, then increased pharyngeal fat deposit, increased body fat, cholesterol turnover and increased estradiol are the important part which plays in diabetes, cardiovascular disease, high blood pressure, stigma, sleep apnea, osteoarthritis, cholesterol and gallstones, and breast and endometrial cancers. So adipocyte dysfunction in obesity can lead to a cascade of problems that acts as markers for complication. So diagnosing and management of obesity leads to improvement in weight and other clinical outcomes, where you need to understand that level of obesity reduction in percentage helps at various part in different complications. So 2 to 5% of weight loss, it improves glycemic measures and triglyceride level. 5 to 10% improves in weight loss, it improves in morbidity, HDL, urinary incontinence, sexual function, and reduce healthcare cost. But 10 to 15% of weight reduction can be helpful in steatohepatitis, sleep apnea, and is linked to reduce mortality. So definitely we should try to increase weight reduction up to this 10 to 15% or maybe more than that, and which may help in various complications related to obesity as well as metabolic disorders. So as compared to patients who do not receive formal documented obesity diagnosis, where 19.7% of patients with formal obesity diagnosis and initial weight loss of more than 5%, whereas 7.7% patients with formal obesity diagnosis had initial weight loss of more than 10%. So here in this important slide, obesity is a chronic disease. We all understand that may lead to weight related complication, and reversing obesity may improve, and it also prevents significant detrimental effects, and the FDA has now defined clinically relevant weight loss of more than 5%. And again, this is the same slide which I showed you before. At different percentage you get different benefits. So at 10 to 15% you get MASH, obstructive sleep apnea, GARD, and knee osteoarthritis problem solved, as well as in more than 15% you can have benefit in cardiovascular disease, type 2 diabetes remission. This is important thing. When you achieve more than 15% of body weight reduction, then only you achieve type 2 diabetes reversion in remission in most of the cases. Cardiovascular mortality as well as HFpEF is also one of the things where you get the benefits. So maintaining weight reduction is the most challenging. We see it is possible to reduce 5 to 10% or even 15% with lifestyle modification. The more challenging is to maintenance of body weight. And for that, we need the support of different molecules. I tell my patient not only to get help just to reduce the body weight, but to maintain it. And the first question from our patients is always, when can we stop the drug? And for that, you need to explain that maintenance is more important even than reduction of body weight. During maintenance, you can even reduce by 1 to 2% every 3 to 6 months. So the more challenging is is to have the weight regain, which we need to stop. And why it is there? Because during this maintenance phase, we have increase in hunger and reduction in satiety. So ultimately reduction in energy expenditure, and which causes weight regain. So patients who underwent intensive lifestyle intervention experience the weight regain. I don't need to explain this thing in detail as paucity of time, but we all understand weight regain is the real problem. So biological adaptation hinders long-term weight loss and often leading to weight regain. Decrease in leptin is one of the important reason, and increase in ghrelin is also important role where it plays. So weight plateau results from complex physiological and adaptation that collectively hinder and continues weight loss and may predispose to weight regain. So weight loss is up to 24 weeks. Here in study it has shown it is possible, but in phase 2 where we have to maintain is the bigger problem. When you stop the treatment, it starts regaining the weight. So maintaining weight loss is challenging. Body's compensatory mechanisms favor weight regain. So pharmacotherapy like semaglutide, tirzepatide could be really helpful if you continue it for longer duration. Orlistat, we have seen it has not so good result in weight regain stopping. So discontinuation of anti-obesity therapy leads to significant weight regain, and we have experienced in last 1 year that tirzepatide or semaglutide, whenever we stop these molecules, they cause the weight regain, and sometimes it is on very high side. So this is the key takeaway and take home message from my side, that globally over 2 billion adults are affected by overweight and obesity, with countries like India, China and USA and contributing to over half of the global burden. In India, there are more than 100 million people struggling with obesity, with higher prevalence seen among women. Abdominal obesity is especially widespread and affecting 40% of women and 12% of men. So you can see the difference between men and women. It is very high. And even in children, the difference is 200% more in NFHS 3 and NFHS 5 data. In India, there are various patient and physician related factors and barriers for weight management. With this, I'll conclude my talk. We have our next speaker here. So thank you very much.
Dr. Malay Parekh, he's going to deliver the talk on redefining obesity care with tirzepatide. So how we can therapeutically intervene on the problem which has been placed before us by Dr. Rutul. So Dr. Malay, his introduction is here. He's a long list, erudite speaker, and he has a very excellent career. So please go ahead.
Yes. Hello, good afternoon. Thank you, Chairperson, Kirti ma'am, and thanks to Dr. Supratit sir, for Dr. Anchin ma'am for giving me this wonderful opportunity and very prestigious conference, EMOCON 2.0 at Kolkata, and thanks to Lily. So without wasting much time, I am going to share the screen and my presentation, redefining the obesity care with tirzepatide. And this is my financial disclaimer. And I am the contracted speaker of the Eli Lilly for this session. As we know, right now, India is the second country in the world in terms of diabetes and obesity population. And if this scenario continue, India will be the leading country in diabetes in 2045, according to IDF. So day by day, diabetes and obesity cases are increasing day by day. And obesity is the lead to the various complications So for this management, we have wonderful molecule tirzepatide. It is a novel GLP-1 and GIP co-receptor agonist and wonderful mechanism of action. We all know in past GLP-1, but what about the GIP? So GLP on the CNS, we know it reduces the food intake, increases the satiety and the nausea level. From the pancreas, it increases the insulin secretion and reduces the glucagon. And from stomach, it reduces the gastric emptying. But the GIP is the wonderful molecule and it has the tremendous effect on the CNS because it reduces the nausea level. So almost all the semaglutide, liraglutide, these are some GLP and GLP has some GI side effect. But this is the wonderful molecule GLP-1 plus GIP. And GIP act on the CNS and it reduces the nausea level. So GI side effect is very, very less with this molecule. From pancreas, it also increases the insulin secretion, and from the adipose tissue, GIP has the wonderful action. It increases the insulin sensitivity, increases the lipid buffering capacity, and also increases the storage capacity and the blood flow. And GIP is a nutrient stimulated hormone with multiple sites of the action. From the pancreas, it is a glucose dependent insulin secretion, and in healthy individual, GIP is estimated to contribute 50 to 70% of the incretin effect. From the fat, it has the insulin dependent fatty acid uptake and mobilization. By that mechanism, it regulates the lipolysis and lipogenesis and directly act on the adipocyte. From the vasculature, it has the increased adipose and the splenic blood flow, and from the CNS, it is the inhibition of the food intake, anti-emetic, and the neuroprotective effect do directly act on the hypothalamus. So GLP and GIP co-receptor agonist, the tirzepatide, the mean half-life is approximately 5 days. So it's perfectly for the once in a week dose, and it's 100% safe and no dose adjustment required in CLD or the CKD patient. What about the approved indication? Right now in India, the two main indications, first is the type 2 diabetes. In type 2 diabetes, you can add this molecule at any level with diet and lifestyle modification. Directly you can start with the tirzepatide. If sometimes metformin is not appropriate due to side effect or contraindication, you can directly as a monotherapy tirzepatide you can give, and even addition to other OHA like sulfonylurea, PIO or anyone except DPP-4 inhibitor. For obesity, if BMI more than 30 or equal to 30, you can directly start this molecule for weight management. But if BMI more than 27 and any complication is there like hypertension, dyslipidemia, obstructive sleep apnea, heart disease or pre-diabetic, directly you can add this molecule or you can start this molecule tirzepatide for weight management in India. So for that we have the robust clinical evidence for tirzepatide weight management was evaluated in robust clinical trial program involving more than 5,800 patients across the SURMOUNT study. In SURMOUNT 1 you can see for the weight management, in SURMOUNT 2 for type 2 diabetes and weight management, and in SURMOUNT 5 weight reduction compared to maximum tolerated semaglutide head-to-head study. So wonderful article published in NEJM 2022 for SURMOUNT 1, the tirzepatide once with therapy for the treatment of the obesity. So you can see here in this study, two arms is there, one arm for the placebo and another arm is the start with tirzepatide 2.5 milligram, then 5 milligram, 7, 10, 12 and 15 milligram. After the 72 weeks of the therapy, it is a phase 3 multi-center randomized double-blind study enrolled in 9 countries and total 119 sites in SURMOUNT 1. You can see the difference between placebo and the tirzepatide. In placebo, only 2.4% reduction, while in tirzepatide with 5 milligram there is a 16%. In 10 milligram there is a almost 21%, and with 15 milligram tirzepatide, highest 22.5% average weight reduction with tirzepatide at the 72 weeks therapy. So, and even the weight loss start is the at least 4 weeks of the therapy. and powerful weight reduction seen at the 72 weeks with tirzepatide. Even the lowest maintenance dose of the tirzepatide helped the one-third of the participant experience more than 20% weight loss. Even the 5% weight loss has robust improvement, but in this tirzepatide, you can achieve the more than 20% loss low. Even after the 20% weight loss, most of the complications it will be reversed, like diabetes remission is there, improvement in the blood pressure, cholesterol, obstructive sleep apnea, osteoarthritis, and many more. So 2/3 of the patient or the tirzepatide 15 milligram experience more than 20% weight loss, and patient with obesity on tirzepatide experience improvement in the body composition. So with Dexastan, with this molecule, the greater reduction in the fat mass than in the lean body mass lead to improvement in the body composition compared to placebo after the 72 weeks therapy. And this is the best slide. People taking tirzepatide experience the improvement in the cardiometabolic parameter at the 72 weeks, 7 to 8 millimeter mercury reduction in the systolic blood pressure, 4 to 6 millimeter mercury in the reduction in the diastolic blood pressure, even 24 to 31% reduction in the triglyceride level, 5 to 8% reduction in the LDL level, and 7 to 8% improvement in the HDL level. So with one molecule, you can get the maximum benefit in terms of the cardiometabolic parameter at the 72 weeks with tirzepatide 15 milligram. What about the SURMOUNT-2? Weight management with type 2 diabetes. In this study, you can see here, it is a phase 3 randomized double-blind multi-center study, total 77 sites and in 7 countries, and the inclusion criteria age more than 18 years, BMI more than 27, and diagnosis of type 2 diabetes with A1C 7 to 10, and treated with the diet and exercise alone or any oral OHA except the DPP or GLP. So one arm is the placebo and another arm is start with the tirzepatide 2.5 to 15 milligram. After the 72 weeks, there is a change in the body weight from the baseline. You can see here, there is a statistically significant reduction in the weight reduction with all the Mounjaro arm 5, 10 or 15 milligram compared to placebo. Even weight reduction of 12.8% with 10 milligram and 14.7% with 15 milligram in this study compared to placebo after the 72 weeks therapy. And percentage of participant achieving weight loss is significantly in Mounjaro 5, 10 or 15 milligram, and most of the patients achieve more than 20% weight loss compared to placebo in this SURMOUNT-2. Even change in the baseline, you can see here from baseline to 72 weeks, there is a significant improvement with p-value very, very significant. And last is the SURMOUNT-5 head-to-head trial with the tirzepatide to semaglutide injectable maximum tolerated dose. So one arm is the tirzepatide, it is a dual coagonist. Another is the GLP-1 only semaglutide. So in tirzepatide arm, 22.9% weight reduction after nearly 3.5 years, while only 16% weight reduction after the nearly only 2 years in therapy. And it is hypothesized that dual agonist of tirzepatide more effectively counter the complex pathway which limit the ability to achieve and maintain the reduced body weight compared with only GLP-1 therapy. So this is the best mechanism for tirzepatide compared to all other GLP like Sema, Lira or dulaglutide. And it is a head-to-head clinical trial. It may remain the clinical question. So in this, one arm is the semaglutide injectable maximum tolerated dose start with 0.25 milligram, then 0.5, then 1, 1.7 and 2.4. And another arm is the tirzepatide start with 2.5 and then increase the dose 5 to 15 milligram. And after the end of the 72 weeks therapy in SURMOUNT-5 study, so tirzepatide maximum tolerated dose demonstrates superior weight reduction compared to Sema maximum tolerated dose. So in semaglutide, you can see only 15% reduction, while in tirzepatide 15 milligram, 21.6% mean body weight reduction from the baseline after the end of the therapy. So there is a robust improvement in the body weight compared to semaglutide at the end of the therapy. Even 1 in the 3 participants taking tirzepatide achieved more than 25% mean reduction in the body weight, while only 1 in 5 was taking the semaglutide maximum tolerated dose. So 36% participant taking the tirzepatide maximum tolerated dose demonstrated mean reduction of the more than 25% at the 72 weeks compared to injectable semaglutide. Even participants those taking tirzepatide experienced superior reduction in the waist circumference at the end of the therapy compared to semaglutide. So in Monjaro, 20 centimeter, almost 7.9 inch reduction in the waist circumference at the end of the therapy compared to injectable semaglutide. What about the adverse side effect? Yes, it is a GLP-1 plus GIP, so there is some gastrointestinal side effect is there, like nausea, diarrhea, constipation, dyspepsia, vomiting, reduced appetite, hair fall, abdominal pain, and injection site reaction. But it is mild to moderate in nature and only occurred during the dose escalation, and it reduced over the time. And these are the some percentage of the participant who discontinue the treatment compared to placebo. The in tirzepatide arm is very, very less. Those patients start the therapy and discontinuation rate is very, very less compared to all other GLP and placebo. So tirzepatide has a similar safety profile to other incretins therapy. GI side effect is there, but it is mild to moderate in nature. So in summary, tirzepatide significantly reduced the body weight by average of 16% with 5 milligram and 22.5% with 15 milligram. Tirzepatide maximum tolerated dose demonstrates superior weight reduction in 21% compared to semaglutide only 15%. Improvement in cardiometabolic parameter in terms of the blood pressure, cholesterol, and there is a waist circumference. And most common side effect is gastrointestinal in nature, only mild to moderate and only occurred during the dose escalation, and it reduced over the time. So to conclude, tirzepatide demonstrates the ability to improve multiple aspects of the metabolic syndrome simultaneously, include the glycemia, blood pressure, and lipid profile while maintaining the well-tolerated safety profile. And based on the finding of the SURMOUNT, we believe that tirzepatide represents a unique, successful, and effective pharmacological strategy with promising result for the individuals suffering from the obesity. By that, thank you so much.
Thank you so much, Dr. Malay, for the wonderful talk. You can join us. Moving on to the next talk of the session, from trials to treatment, integrating tirzepatide into the clinical practice. For this, I would request Dr. Ajay Tiwari to kindly come on the dais. Sir actually doesn't need any kind of introduction. He's a very important person in this thing. So he can, I think, sir, over to you.
Thank you, Dr. Sahi, for the kind introduction. And I will be talking on trials to treatment, integrating tirzepatide into clinical practice. So this is basically a sponsored talk from Eli Lilly, and they have got some housekeeping rules like taking any photos or videos during entire meeting, taking screenshots of slides. So this is basically what they want to propose. So I've been sponsored by Eli Lilly for this talk. But I think in the current scenario, when we are having a bombardment of off-patent drugs, so talking about the originator molecules is very pertinent, and we should be discussing them in great detail, because this is the time when we have to choose between the right and wrong, or the gray ones. So that is what I want to talk. So the approved indications for tirzepatide is basically, it's a very practical sort of, and I think it will be more of a revision because most of us are using this particular molecule. So in type 2 diabetes, tirzepatide is indicated for the treatment of adults with insufficiently controlled type 2 diabetes as an adjunct to diet and exercise. And we all know that we are having an A1C reduction of around 1.8 to 2%. So that is very important, and in this weight loss halla gulla, we are missing out very important perspectives as regards to GLP-1 analogs, that is the good A1C control they are providing and their ASCVD benefits. So in addition to other medicinal products for the treatment of diabetes and chronic weight management, tirzepatide is indicated as an adjunct to a reduced caloric intake and increased physical activity for weight management, including weight loss and weight maintenance in people with more than 30 kilogram per meter square of obesity, or 27 kilogram per meter square to 30 kilogram per meter square in the presence of at least one weight-related comorbid conditions, hypertension, dyslipidemia, OSA, cardiovascular disease, pre-diabetes or type 2 diabetes mellitus. And it will be lower for Southeast Asians because we have 27 and 25 for people who are from Southeast Asian or South Asian origin. So coming to, we have been discussing about these trials, and these trials are very pertinent because they are the foundation stones on which the entire obesity management has come and which has shown us that these drugs can go much, much beyond what we have thought in our clinical practice. So it is Surmount 1, Dr. Malay has already discussed about this. So it's about weight management. Surmount 2 was about weight management in type 2 diabetes. Surmount was weight management after intensive lifestyle modification, and Surmount 4 was weight reduction maintenance. So that is very pertinent because now we will be bombarded with questions in our clinical practice, when to switch, when to stop. So these are the most pertinent questions. And Surmount 5 was basically a weight reduction comparison between semaglutide and the maximum tolerated dose of semaglutide and tirzepatide. So that was an head-on trial. So the most important question, and I think this will be the question that is put to us every time, how long and when can we discontinue? So this is the question that is being asked by every patient because of the injectable nature of these therapies. So we have to understand what we need to answer them. Firstly, we have to give very realistic picture. So don't give false promises. That is very, very important, and we have to understand what happens if we stop tirzepatide. So we have a structured trial for that, and that was a Surmount trial. So where they used tirzepatide maximum tolerated dose versus placebo in participants with obesity or overweight with obesity-related complications, excluding diabetes. So they went with the usual titration over 0 to 36 weeks, that is from 2.5 to 15 milligram as we do go, or 10 or 15 milligram, and they had so basically for 36 weeks these all patients were continued on this molecule, and thereafter they were randomized to, after 36 weeks they were randomized to either tirzepatide, that is 10 milligram or 15 milligram, or the placebo. So tirzepatide and placebo were administered subcutaneously and as an adjunct to reduce caloric diet and increase physical activity. So the baseline lifestyle management was continued in both the groups, and what we saw is the phase 3 multi-center randomized double-blind placebo-controlled trial, and the primary endpoint was maximum tolerated dose 10 milligram or 15 milligram percentage change in body weight from week 36 to week 88. So all these patients were continued for 36 weeks on maximum tolerated dose, that is 10 milligram or 15 milligram of tirzepatide, and thereafter they were divided into two groups. One was a placebo group and another was continued with the maximum tolerated dose of tirzepatide. So this is what was shown as regards to the two curves. So we have this over there. So those who continued on tirzepatide maximum tolerated dose, they had a further reduction of around 26% at week 88, and those who stopped and were shifted to placebo, they also had some weight loss that was to the tune of 9.5%, but this, if you see, the curve is going upwards after we have stopped using tirzepatide. So that is important, and total weight reduction in participants on tirzepatide from week 0 to 88 was 26% versus 9.5% participants who stopped taking tirzepatide at week 36. So this curve has to be shown as an illustration to the patients that if you stop it, because you have to understand that once we define obesity, we have to understand that it is a chronic relapsing disease, and once we stop these medications, the body will start going to the set point, and over a period of time, again we will be going back to where we started from. So that is very important, and this is to be understood, and this was as regards to the two groups, how much of them were able to have a weight maintenance target at week 88. At week 88, a significant greater proportion of participants continued. Maximum tolerated dose versus placebo maintained more than 80% of the body weight loss during the 36 week. So that is important, 93.4% versus 13.5%. So that shows us that these molecules are to be continued because we have to understand that obesity, it always comes back, so they have to be continued throughout. And then as regards to the adverse reactions were basically nausea, diarrhea, constipation. The GI side effects we all know, that is the problem with these drugs, and they were the most common. And the gastrointestinal adverse reactions primarily occurred during dose escalation and decreased over time. So that is very pertinent, that why we have to start with the lowest possible dose and we have to go slow and accelerate the dose accordingly. And then also we have to define what amount the patient is tolerating, because many patients, they are tolerating 10 milligram, 15 milligram. So that is basically we have to understand that it is not that we have to accelerate up to 50 milligram. If you are getting good results with a lower dose, 10 milligram, 7.5 milligram, that may be a different case for our Indian population because we have lower BMIs. So that all has to be an individualized therapy, and that is to be understood. Then coming to the practical considerations with tirzepatide. So this is, I think this will be more of a revision. They have got these colored four injections plus one injection for the priming purpose. So this is what they do. They start with 2.5 milligram per week, and this is to be given for 4 weeks, and thereafter you have to accelerate to 5, 7.5, 10, 20, 12.5 and 15 milligrams. So these, specifically these injections have a different color coding so that there is no confusion as regards to this. So start with the lowest possible dose, and over 4 weeks we have to accelerate accordingly. Then a very important question and pertinent question that is being asked and which was being discussed in the previous session also. So what we need to do. So if a patient is having acute pancreatitis, tirzepatide should be used with caution in patients with history of pancreatitis. So let's accept it that why should we be giving in these set of patients? Patients should be informed on the symptoms of acute pancreatitis. So it can start per se also. If pancreatitis is suspected, tirzepatide should be discontinued. If the diagnosis of pancreatitis is confirmed, tirzepatide should not be started. So that is very important. Diabetic retinopathy, this was basically, this is what we call as NAI1. So that is, this has been reported, and this has been reported because of the rapid reduction in the blood glucose levels. But that is a problem, and now we have some points which can point. So those patients with non-proliferative diabetic retinopathy requiring acute therapy has not been studied in patients with non-proliferative diabetic retinopathy requiring acute therapy. With proliferative diabetic retinopathy or with diabetic macular edema, and should be used with caution in these patients with appropriate monitoring. So we have to be very clear about these things, that if these patients already have NDPR or PDR or having macular edema, they should best be avoided because we know that they can precipitate or exacerbate these issues. As regards to pregnancy, tirzepatide should not be used during pregnancy. A very clear indication. If a patient wishes to become pregnant, tirzepatide should be discontinued at least 1 month before a planned pregnancy due to its long half-life. And that is what is very important, that we have to tell these patients about the precautions that to be taken if they intend they are going to do any treatment, because this is to be washed off for at least 1 month prior to the pregnancy. And lactation, it is unknown where tirzepatide is excreted in human milk. A risk to the newborn infant cannot be excluded. So better avoid when the mother is lactating. Hepatic and renal impairment, no dose adjustments is needed for patients with renal impairment. They have been safely used up to 15, but they are not studied beyond 15. So we have to be cautious, and also to understand that the side effect profile of these patients may have a bearing on using these patients in very low eGFR levels. So again, the discretion of the clinician will be of the paramount importance. No dose adjustments is needed for patients with hepatic impairment. So that could be a positive thing, but we also have to understand that the gastrointestinal side effects may force us to, may not be very feasible to use these agents with very low eGFRs. So the dosing in combination with existing therapies and in special populations, metformin, SGLT2 inhibitors, current dose can be continued. When we are using with secretagogues or insulin, obviously we have to reduce, and what we were discussing, 20 to 30% reduction in the dose may be required, but that may differ from individual to individual. And dosing in special populations, no dose adjustment is needed based on age, gender, race, ethnicity, or body weight, no license in children less than 18 years. So not to be given in children less than 18 years. So the managing side effects, that is very important because these things are to be told to the patients, eating smaller portions more frequently, being mindful to stop eating once full, avoid eating when not hungry, staying hydrated, avoiding high fat or spicy food, and moderate intake of alcohol and fizzy drinks. So all these things are to be told to the patients. Drug interactions, insulin secretagogues or insulin, obviously they can reduce. Oral medications, tirzepatide slows gastric emptying, potentially affecting absorption of oral drugs. So we have to be careful when we are using them with other drugs. Monitor efficacy and safety when co-administered. Hormonal contraceptives may reduce the efficacy of oral hormonal contraceptives due to delayed gastric emptying. So these all things are to be understood. Then as regards to missed tirzepatide dose, so that is what we have to understand. So if only 3 days have passed, you can give it, and if after 3 days, you need not do it, and you just have to go for the next dose. So that is what it is. So my key takeaways are multiple global and Indian guidelines now recommend pharmacotherapy for obesity when lifestyle changes are insufficient. And lifestyle interventions alone typically result in modest short-term weight loss with high rates of weight regain. So that's the story, and this vicious cycle of weight loss and weight regain keeps on. And these drugs, incretin therapies, has given us insights as regards to the pathophysiology of obesity, and understood that this is a relapsing disease and we need to have treatment for that. And single target drugs often have limited and variable effectiveness for weight and metabolic control. Sustained weight loss and maintenance requires ongoing therapy, and initiating tirzepatide starts at 2.5 milligram weekly and escalate gradually, monitoring for GI side effects and drug interactions. So thank you for patient hearing.
As usual, a very lucid talk. Thank you so much, sir. I would request the rest of the speakers also to kindly come on the dais for the panel discussion.
I know there is a fight going on between ghrelin and leptin, and ghrelin is taking the upper hand because it is already there announced lunch at 2 p.m. and physiological, so we are feeling hungry. So I will have one question each for 3 speakers. Excellent speech, and you have made it so clear. There are not many questions left. So first I would like to ask Dr. Ruchul regarding its concept of obesity. How does it sell nowadays? I mean, amongst referring physicians and amongst the educated patients, like whether they are considering this as a separate disease, a condition for which you need to seek treatment from early on. Because I know you have been running a very successful obesity clinic and you have dealt with a lot of people. So just brief answer.
So a very nice question, as it is very important. Earlier, like before at least 1 or 2 years, I would say that patients were not considering going to any obesity clinic. A few of them, like maybe 5 to 10%, they were reaching directly to nutritionists mainly. We were not part of obesity clinic mainly, maybe at
we didn't have much to do actually.
Yes. So after very good marketing from all the pharmaceutical companies who has played a major role, and now because we have the molecule, this is why also when we are getting good results, the patients themselves are also coming and considering that it is a disease and now treatable disease. Unless it is treatable, they were not considering much.
So obesity as a concept was already there because VLCC and other stuff also, their business was based. So do you see any change in perception regarding that kind of obesity treatment and this kind of obesity, what we are doing?
Yes.
That this is a disease, not a cosmetic condition only.
Yes, definitely. As I already told that we are seeing very big billboards at every place, like in airport, or even if you see on the roads, you are going to see the big billboards, and they have written that obesity is a disease, from various companies. And this is why patients' perception is also changing. And we are also counseling better and more. And we are giving little more time to each and every patient.
We are more confident now.
Yes, we are more confident as we can treat it.
Yeah. So I think we are on the right path. Maybe it will take more time. So next question to Dr. Malay, regarding treatment with various agents, including tirzepatide. Various others are there, a lot of them. So sometimes you use a particular agent for, suppose for diabetes also, or hypertension, and then you meet the end of the road, then you try to change to the other molecule. It may not be fully justified, but you just want to take a chance. Do you do that often in your practice? And do you believe that we should give a chance to the patient by switching over to the other? And how do we switch over to the other drug? You start at a kind of an equivalent dose, or from the trials, or you start from the low dose onwards and climb up?
So it's a very practical question. Earlier, before the GLP-1 era, we just start the metformin and DPP and all the parameters. But once the GLP came, our treatment is changed. So earlier we used the semaglutide, but now tirzepatide is come, and it will be the totally game changer. So after the tirzepatide came, right now, earlier we just treat the glycemic, fasting and PPBS and glucocentric approach. But now the scenario has changed. Now we have to think beyond the sugar control. We have to prevent all the complications, micro and microvascular complications. And for switching, tirzepatide, the guideline is start with the 0.25, then 0.5, and then the start 5, and then 7, then 10, and then 12 and 15. But if the patient on the, suppose semaglutide 7 milligram tablet or 14 milligram tablets, you can with your practical and a patient's tolerability, you can directly from sema to tirzepatide, you can switch over, but it is totally practical, totally your experience, patient's perspective.
Okay.
But ideally, there is no clear-cut guidelines for that. But most of our studies suggest that if you start with the low dose and then gradually increase the dose, then it will be the more beneficial, no side effect, and patient will take most of the maximum result patient will get.
Just one brief question regarding CKD. Oh, okay. For him. Yeah, please.
We have 2 to 5% of non-responders in our patient category. Maybe you're on that patient, working on that patient. If it is the patient of no use switching, technically no, but yes, we are doing it. And in few patients, we are getting result also. And yes, you have to manage, you have to titrate it properly.
Very good point, because even with the highest dose, you can see that you have 95 or 96% success. So 4, 5, 6% may not succeed with this. But it's too early to say. We may have to use it for longer. So my brief question to you regarding two groups, advanced CKD and CLD. How safe they are, and what would be your GFR cutoff to start this medicine?
Okay, so we have studies where they have shown that around 15 EGFR you can use them safely, but beyond that we don't have any data as regards to that. This is the current state of affairs as regards to CKD. For hepatic impairment, they have shown that across the spectrum it can be used. But I was putting this point before that we have to be very careful in these patients, because they already have, because of the uremia and other things, they've got a lot of gastrointestinal symptoms.
People who already have cirrhosis.
Advanced cirrhosis. Obviously, so advanced cirrhosis, that may be, there is a very interesting thing now coming up. That is with regards to MASLD also. So we have got studies with the Essence trial and this tirzepatide trial also, where they have shown that you can go for a reversal of fibrosis. Obviously, there are no studies on cirrhosis, established cirrhosis, but in fibrosis and advanced fibrosis, you can have reversal up to 2 stages. Both trials, the NASH trials, have shown this thing. So that may be a very beneficial effect, but in established cirrhosis and ascites, obviously there will be, you should not use them.
I know it is already 2 p.m. I think. So we should wind up. And if there is any question from the audience, if not, then I think from my side, I'll hand over to the chairpersons.
I think we'll all wind up and move for the next session.